Excuse me, Prof. Quick question. The panelists, are they aware that they have to come in this morning in the sessions morning, even before their talk?
They're supposed to, I don't know whether they know that they're supposed to come earlier, but they
Okay.
know that they're on today.
The
We are
time, all right.
communicating. So I'll get the
Okay, okay.
second speaker to stand by lah. Sebab sekejap je 15 minutes kan? Okay.
Okay. Itulah. So
Uh,
that's what we're afraid of. Takut nanti by the time the
yes, yes.
speak
Betul?
the first session dah habis, orang tak masuk lagi itulah. But thank you
Kan?
so much for arranging, the speakers.
Yeah, I'm sorry that we are so like top heavy. Banyak sangat. But I think
No,
it's
don't be
like
sorry. I think that's actually great.
their work. Yeah, they just want to share their work because we need to also have workshops, kan? And presentations. So I think
And
sort of
we're happy to provide that platform for all of you. So all the
okay.
best.
All
Okay,
right, thank you.
thank you.
Assalamualaikum. Sharifah, do you want me to straight away go straight to moderation ke, or you going to do some intro? You will be doing.
No, actually, Dr. Shafiq will be, will
Right,
give the
right.
intro.
Okay,
Yes, and then he will pass it over to you.
okay, okay, all right.
All right. Okay.
Hi, Dr. Lai.
Hi, Prof. Aisha, morning.
Morning. How are you?
Okay, good.
Okay. So you want to try and share your slides in case, but it's only 3 minutes to go lah. But it should be
Okay.
okay, yeah? It should be
Boleh,
okay.
boleh.
All
Should be
users.
okay. I can try now.
Yeah.
Alamak. Tak boleh pula.
You
Kalau
have
nak share slide tu, share window ke apa?
Nanti saya.
share window will be better.
Okay.
Yeah, correct.
Usually when you open it up, you can see Microsoft PowerPoint. Then you make sure there's only one PowerPoint lah on your desktop or something like that.
Yeah, I opened already the PowerPoint on my desktop. Let me see.
Okay.
Let me try again. Can you see now? I thought I shared already, no?
No.
Let me see. I should go to, where's the share PowerPoint? Just now it was there.
Share
Okay,
screen.
share
kat
screen.
bawah.
And then share.
You will see the PowerPoint window and then you pick that window, the PowerPoint window.
Share screen. Share screen, right? Whiteboard, iPhone, WhatsApp, Microsoft Teams, download, present. Oh, share screen. Then I just put share. Can you see it now?
Yes, yes. Can see. Okay. Irene, okay? You want to try?
Sekejap. Okay, I will try. Sekejap
Shadul, you're all right? Dr. Shadul is...
Yes, Prof. Assalamualaikum.
Waalaikumsalam warahmatullah. And then Hikmah is a digital native, so it shouldn't be any problems, I think. Hikmah?
For me, it says you cannot share screen. Oh, because someone else is sharing now.
Okay, then maybe we, Dr. Lai, you got to unshare?
I stopped share already.
It's 9 o'clock.
All right. Okay, so I think we shall...
Hello, everyone.
Hi.
So,
Dr. Shafiq ke?
Husna can also try.
Hello.
Sorry, what is it?
Hello, everyone.
you see,
Shafiq.
Can you hear me?
Prof, you see my one?
Yes, we can.
Okay,
Okay, great. So I stop.
Hi, Professor. We're going to start because we're already live.
Yeah, we're going to start already, yeah? Okay.
Okay. Assalamualaikum and good morning, everyone. Welcome to the day 2 of the FOM, Faculty of Medicine Research E-Carnival 2021. Yesterday, we have the pleasure of listening to the brightest mind and proponent for the patient and public involvement in research. Our speakers have highlighted the importance PPI in our research as well as from the patient's perspective. So today, in the morning session, we will listen to a group of oncologists, cancer researchers, enthusiasts who will give us the overview of their work to combat cancer. So out of no stranger to University Malaya and in fact the whole Malaysia, one of the best researcher in oncology. So I will pass the spotlight to Prof. Aisha.
Thank you, Dr. Shafiq, for your very kind introduction. So today we're going to have 2 sessions, one on early cancer diagnosis and the next one at 11 on breast cancer survivorship. So let me introduce you to Rebong. Rebong is reducing cancer early diagnosis barriers in the urban B40 group in Selangor. So we are focusing on 4 top cancers in Malaysia: breast, colorectal, lung, and cervical cancer. So this year, the Global Can has published their latest data on the incidence of cancer worldwide. You can see that the pink has overtaken the blue. So breast cancer now is the commonest cancer all over the world, but you can see in pockets, lung cancer is still there, and prostate cancer as well as cervical cancer remain very important global cancer diseases around the world. So in Malaysia, we can see the commonest cancer, and this is not whether it's male or female, is breast first, and then colorectal, lung, and then lymphoma. You can see the other cancers like cervical cancer, prostate cancer, the incidence is about the same. So why are we worried about cancer in Malaysia? So cancer in Malaysia, the issue is there is disparity in survival rates. So if you can see, Malaysia is not doing very well. Our 5-year relative survival is only about 67% compared to 89% in Japan and 80% in Singapore. So we know that there are disparities in private and public hospitals. So there are higher survival rate, and these are data from UMSC and UMMC showing a difference of about 16%. But we have found that the reason why this occurs is because of the stage at presentation. So the trends are not looking very good. 2 cohorts of patients from the Malaysian National Cancer Registry has shown an increase in stage 3 and 4 breast cancer from 43% to 48%. So there are multiple issues with delays in presentation, delays in diagnosis, and delays in treatments in Malaysia. We have a national strategic plan for cancer control. However, this has not translated to pilot projects or even nationwide projects that may help improve the stage at diagnosis. So then came us Rebung project, which is funded by the IIRG Cycle 2 as well as the MBPJ seed grant. And we are made up of an interdisciplinary group of researchers. I am leading the sub-program 1, which is really looking at health systems. The sub-program 2 is Dr. Lai, who is looking at the empowering social, cultural, religious factors related to early diagnosis. And the legal aspects, Dr. Irshadul Karim from Faculty of Law is also looking at the issue of patient information sharing and how we can navigate people through the systems while still using the policy of the patient, the PDPA policies, right? Okay, the third sub-program is led by Dr. Liu Kong from Primary Care, and he is looking into how we can build a strategic extension communication campaign among the urban B40 women using a community-based participatory action research approach. And we have with the sub-program 4, leaders are Dr. Hyrene as well, or now Professor Hyrene and Dr. Suniza. They are developing an online training module, namely for the community navigators as well as the general practitioners. And the last sub-program is Professor Sarinder Kaur. At the moment, we are still looking for funding. And this is how we're going to try and do the monitoring and evaluation of these cancer care pathways using a tech-based community hospital cancer navigation tool. We have 4 students or research assistants in our program. Hamiza, a PhD candidate, Nur Husna, an MSc candidate, and Tila, who has now got her MSc just with the work that she has done with Rebung, and also our PhD candidate, Nur Hikmah Lutfi, who will be presenting later of her work. Right, so these projects will culminate into a strategic extension communication campaign and also provide some tools, which are the training modules, to implement a single site pilot project in Taman Medan. So my first sub-program, I am going to present to you the stakeholder engagement, analysis, and management. This is really when we are doing something as complex as this, there are structured implementation strategies that have been designed to target systemically identified barriers that can improve treatment uptake. So this planning, implementation, evaluation, iterative improvement of translating intervention and treatment guidelines into practice are available frameworks to do it. And the key principles include stakeholder engagement, application of theoretical frameworks, and rigorous ongoing evaluations. So the engagement process is really, the literature is really more heavy in the business management, international development, community psychology, and natural resource management. Not much has been written in the medical sphere. We know that engagement process can be externally driven, like how we have the City Cancer Challenge, where we have an external foundation that is helping the local stakeholders to do solutions for cancer control. But we also have self-organized efforts where local groups active in cancer control can actually pull together their resources and to do more better management of cancer control. So the right balance and timing of stakeholder engagement is the critical first step. So in particular, we must focus on key stakeholders, and this engagement needs to happen as early as possible, and there must be a plan for adequate period of engagement. And also the socio-ecological condition relating to the rights and governance play an important role in the success of any projects. So this research combines the extensive work of Schiller and Berlin on project stakeholder analysis related specifically to the context of early diagnosis cancer control that is applicable in Malaysia. Guided by their work, we identified important stakeholders in cancer control implementation projects in the context of Malaysia and to the actors within the micro level of the district. So our pilot project is very specific to a single pilot location, which is Taman Medan. Through an iterative snowballing technique through consultations of stakeholders, we identified the Rebong stakeholder identification and management framework relevant to the Malaysian context. So the aim is to analyze the iterative process of the pre-implementation of Rebong and the importance of early stakeholder engagement in an impact-oriented research, which we call Rebong, is to really to improve the early cancer diagnosis among this underserved urban community. So based on this result, this framework for pre-implementation planning and effective stakeholder management is proposed that would help project professionals to manage their local cancer control implementation projects. So we have developed 6 relationships with 6 major key stakeholder groups in our target setting. I will explain that later. And we are also informed by the gaps in the relevant literature so that we can develop a framework for identifying, categorizing health and non-health stakeholders who are important in cancer early diagnosis. The framework was created through an iterative process of stakeholder identification and categorization. And of course, we use a lot of manual ways by visual charting and then corresponding with expert informants to obtain more practice-based insights. So all these processes we have collated, and through exploratory qualitative approach, looking into consultative engagement minutes, reports, and existing cancer control documents, an iterative way of looking at it. And when we do this, we also make sure we have member checks being done through the feedback of our consultative meeting minutes to our key stakeholders. So the phases of stakeholder engagement were analyzed, and a step-by-step framework was built to produce the Rebong Early Cancer Diagnosis Stakeholder Engagement Framework. These study activities have been approved by the NMRR and the UMMC Medical Ethics Board. So we recruited 62 participants for brainstorming, and this included potential decision makers, program implementers, and program participants. 62 responses from health professionals, administrators, members of the public were pulled from 23 consultative meeting minutes. Manual methods were used to organize the teams. So this pre-implementation phase of Rebong, where Rebong is actually the pilot that we will be doing in Taman Medan, we found that there are 4 steps towards ensuring the pre-implementation phase is done in a very successful way. So step 1 is really to come up with a common goal with the stakeholders, where right now we are looking at early cancer diagnosis for 4 top cancers, which is breast, colorectal, lung, and cervical cancer. And step 2 is really the stakeholder analysis, where we map the health system beneficiaries, which is mainly Ministry of Health, as well as the Selangor State Government. And we must map the community, the policymakers and the academics and the political leaders also, to ensure that we are able to provide a better outcome. So the analysis is really looking at the interest and influence metrics, and we are doing stakeholder consolidation, and we are identifying the roles and responsibilities of all our stakeholders. And the management part is really looking into project communication with our stakeholders. And lastly, we will be looking into the task definitions of each stakeholder. Step 3 is the alignment exercise. So by doing the power influence alignment matrices, we should be able to find each strengths and weaknesses and find ways to actually consolidate the program. So it's important to align to, important to know there are stakeholders with contextual knowledge, and there are also stakeholders that have policy knowledge. And how we can come up with an implementation solution is that we marry all this together, because sometimes policymakers, when they make decisions, they are not very aware of the contextual aspects of it. Step 4, the last one, is the action plan metrics, where we will be holding a stakeholder meeting on the 13th November this year. So we think about doing the mapping. Okay, this is all very, these are all the meetings that we've had. Actually, there are about 23 of them. And what is more important is that we have multiple stakeholders that we have mapped out. We have identified their tasks. And you can see that key stakeholders or our research beneficiaries are mainly Ministry of Health and the Selangor State Government. We have NGOs that are both from cancer and non-cancer groups that will help to shape the campaign that we will be doing. And we have multiple NGOs that are going to contribute to the support the community as well as the health centers. So we have 4 clinics in the government side, as well as the private GPs that we will be engaging for this project. So I think later on you will see this slide in multiple different colors, but essentially this is our progress so far. So we will be engaging our NGOs and clinics because we have sort of mapped out their roles and responsibility during the Rebong campaign that will take place between February to March next year. And these community campaign packages include 3 community campaign packages, which is really the messaging, the channels, is how we communicate early diagnosis messages. The second one is the community navigator package, where local leaders, NGOs, mosques, churches, and all that will actually be our community navigators. And the last one is the GP training package. So all the 5 sub-programs will be contributing to all the tools that we will need to carry out the Rebong campaign. So the 3 things would be the strategic communication campaign and the 2 trainings of the community navigator and the clinic kesihatan or the primary care doctors. So don't forget, we will also need to evaluate our program. So it is quite complex. So having many students and many people in different sections that they will talk more about later, you will learn that we will be building in the evaluations for all these processes. So in conclusion, have a single vision and mission. Partnerships are based on respect, trust, legitimacy, fairness, competence, and accountability. Engage early and strategically with key stakeholders, and we can together co-create new knowledge and partnership. And don't forget, we need to monitor and evaluate. So that was my last slide. So we won't take any questions. I will now pass the baton over to Dr. Lai Swatyan. I will end my show. Okay, Dr. Lai, I have stopped sharing.
Okay, thanks so much, Prof. Aisha. I will, yeah. Okay, the screen is being shared now. As you all can see, this is sub-program 3, and as Prof. Aisha has mentioned, the aim of the program is to look at the empowering and also disempowering social, cultural, religious, and legal aspects towards early diagnosis of cancer. Because when we talk about cancer, it's not just a medical approach to solve it, but it's actually exploring beyond a biomedical approach to, to ensure that there's early diagnosis, which is why we also look at the social, cultural, religious factors as well. And in my team, there are 5 of us, namely myself, Dr. Vilashini Somaya, my colleague, and Ms. Noor Husna, who's actually pursuing her master's in gender studies on the same topic. And she has just passed her proposal defense. So she's in the initial stages, but she has been a very able research assistant. So I'll be presenting on the social, cultural, and religious aspects together with Nur Husna, because I think it would also be very good process as part of her master's as well. And the legal aspect will be presented by Dr. Muhammad Ashado with Ms. Tilagawati Rama. In terms of the presentation, there will be three parts to it. The first will be on the process of collecting the data in terms of the stakeholder engagement, in terms of how we collect the data, and then lastly, the preliminary findings. Yeah, I will pass over to Ms. Nur Husna to do the presentation on the process itself and also the data collection. And after that, I will come back and do to speak about the preliminary findings. Over to you, Husna.
Okay. Thank you, Dr. Lai. And good morning, everyone. Thank you for being here today. Okay, let me just. Yeah. Okay, can everyone see the screen now?
Yes, we can see that.
Okay.
Okay.
Okay. So as Dr. Lai's research assistant, my job is mainly to assist her with the interviews. So for the process of data collection, in the initial stages of collecting the data, we started with having stakeholder meetings, engaging with the Taman Medan community leaders, and also we had meeting at Klinik Kesihatan Taman Medan as well. These are some of the few meetings that we had with the stakeholders prior to starting the interview. And other than physical meetings, we also had online stakeholder engagements. This was during the strict MCO. So after that, we only had online meetings with all the stakeholders. Ustaz Hashimi is the Nazir of Masjid Jumhuriyah, and Mr. Jeffrey Pang is the chairman of Persatuan Penduduk Putrajaya. And the purpose of having these stakeholder meetings is to introduce the project, Rebong, and also the team members of Rebong. And to also secure the list of interviewees. For example, from Ustaz Hashimi alone, we managed to identify cancer patients among the Taman Medan community members. Yeah, and also in addition, we also created posters to be shared on WhatsApp groups and Taman Medan community Facebook groups to reach some of the interviewees. All right, so the location of fieldwork, terrace houses and flats at Dasar Mentari, Taman Medan, and Taman Datuk Harun, or the surrounding areas served by Taman Medan Health Clinic. So these are some of the interviewees' houses. Some of them actually preferred to meet at the houses, and also some of them wanted to do it at the Masjid Jumhuriyah. So before district MCO was implemented, we actually managed to do face-to-face interviews at their houses or the masjid. But after that, during the district MCO, we only managed to do online interviews, be it through phone calls or video calls. All right. So the methods that we use for our data collection is purposive sampling. We have three groups that we are targeting. We are the first group, second group, and third group, which each of them we have different characteristics that we look for in each interviewees. But all of them across all three groups, they have to be from Taman Medan, Taman Datuk Harun, or the surrounding areas near Klinik Kesihatan Taman Medan. And from the interviews, from the interviewees that we have interviewed, we also collected other contacts. Yes, this novel sampling through referrals of those interviewed, and each interviews lasted for 1 hour to 2 hours. Another method that we use is triangulation, where we collect sources, where we collect our information from multiple data sources. For example, we didn't only interview the cancer patients, but we also interviewed their family members, their carers, be it their siblings or their daughters or their sons, their partners. We also interviewed the medical staff at Klinik Kesihatan Taman Medan, because Klinik Kesihatan Taman Medan is the place where a lot of people go to do their checkups and everything. And we also interviewed community leaders, mostly from the Masjid Jumhuriyah, the AJK of Masjid, and also some of the representative from, for example, from MBPJ, from JKM, yeah, those who are responsible those who are responsible for Taman Medan community. All right, so throughout the process of collecting data, there are some challenges that I face. For example, last minute change of mind. So some of them would actually say that, okay, I'll be free tomorrow. But then when we were about to start the interview tomorrow, then suddenly that they wouldn't be available. So like regular changes of interview time, and also the availability of participants, especially during the MCO, which is very understandable. So I have to dedicate my whole time to their availability, yeah, because of the constant changes. And also there are some differences in the participants' reasons to be interviewed, which may influence the given answers. For example, some of them actually showed genuine interest to share and learn, but also some of them, very few of them, they approached me to participate in the interview because they are in need of immediate financial aid, as every participant, every interviewee will be given RM50 ringgit token. Okay, so very quickly, summary of the interviewees. We have 3 groups, as I mentioned just now, which for now we have the total of 53 participants. So the group 1, we have cancer patients and carer of cancer patients. The total are 22 people. Group 2, those without cancer or those with no experience of having life-threatening disease, or those with life-threatening disease such as heart disease and other life-threatening disease. And group 3, we have healthcare providers from the Klinik Kesihatan Taman Medan, and also hospitals like Hospital Shah Alam. Okay, so, out of the 53 participants, we have 37 female and 16 male. So if you can see, we arranged the participants from the highest to the lowest. So the highest across all 3 groups, we have more female than male. We also have more Malays than Indians and Chinese. And for group age, we have, so these are the breakdown. We have 17 people aged from 18 to 30, 13 people aged 41 to 50, 9 between 31 to 40, 8 between 51 to 60, and 6 people are between 61 to 80 years old. All right, so summary of the interviewees. I would like to repeat this, that we have more female than male across all 3 groups. We also have more Malay than Chinese and Indian across all 3 groups again. And yeah, for group 1, group 2, group 3, group 1, as you can see, we have very balanced distribution across all group ages. And the highest here, as you can see, between 51 to 60, because group 1 is for cancer patients and carer. So we have more cancer patients in group 1, age 51 to 60 years old. And then group 2 and group 3, yeah. Okay, I hope that's clear. I will pass over to Dr. Lai. Thank you.
Husna, next slide, please.
Okay.
Okay, let's now look at some of the preliminary findings of the research. In terms of healthcare practices for B40, when it comes to annual checkup, typically they don't go for any annual checkup unless if it's required, for example, for their work or for their study. And they also do not differentiate, whether it's diagnostic tests or not. And in terms of the hospital that they go to, it tended to be government hospital. Nevertheless, during our interview, we find that some also, come to UMSC because it's near, and some of them also has medical insurance, so that's why they could also afford going to even a private hospital. A few, not many. And typically they say that they go to the clinic or doctor when they have ailment, but on the other hand, we also interviewed those who said that they tried the traditional medicine first, which means that by the time that they go to see the doctor, their diseases, their illness is actually at the very advanced stage. Next, please. Next, please. Husna, next slide. Okay. Next, please, Husna. Okay. In terms of their perception of cancer, we find that also, there are differences compared to all the earlier studies. Their views are more multifaceted, and it also depends on the situation they are in. For example, those who actually have family that have cancer, for them, they don't necessarily look at it as death, especially when their family members manage to survive. Though, of course, there's still lots of fear when they talk about cancer, when we spoke to the various groups. And also, there are also those who actually, though it's rare, who look at it, cancer as being caused by black magic. Yeah, and also, in terms of the context, some also look at it as sin, and that's where also the stigma is like, because you have sin, therefore you get cancer. And typically, they are not clear of the risk factors. Though those who are more knowledgeable, especially if they have family who have went through it, some would even say it's genetic and also related to the food that they eat. Next slide, please. And in terms of stigma, as mentioned, there's stigma to it because also, especially for one patient, she was saying, she actually try and avoid some of her family members or relatives because they think of cancer as being due to sin. Yeah, but on the other hand, when we interview other persons, including the religious leaders and whatnot, they also provide a different take on it. They're saying, having cancer is also part of a religious purification. That means you are cleansing yourself of sins. And also there are those who are saying also, who are we to judge, right? At the end of the day, in terms of relationship, is between the person and God. Yeah. But in general, I think that's actually more acceptance, though from the data, it seems that people also still find it difficult to talk about cancer. And yes, in terms of physical and mental effects, it's there. They'll be bald, thin, and they become tired quickly. Those who we interviewed actually spoke about that as well. And of course, for women, when their breasts are being taken away, they find that it affects their identity. And not just that, it also affected their relationship. Like, one of the cancer patients we interviewed, talk about her, her partner leaving her. And even the man that we interviewed was saying that, he is afraid that the partner will look for another person, things like that. So, yeah. And of course, the impact in terms of depression were also spoken about. Next, please. And in terms of the sources of info and how to reach them, the greatest distinction from the preliminary findings is the age group. When it comes to those who are younger, the younger group, they are more tech savvy, whether it's social media, they look for information on Google on their own. They even look for a cancer support group on social media on their own. And some are even linked to social media influencer. But for the elderly, it's a different picture. Usually they learn and share, and in terms of stories from their family, relatives, and friends. Some of them are just not tech savvy. Yeah? And for them, they also mention TV and brochure as important sources of information. With regards to the sharing on how sources of info can reach them, there are actually different ideas. Some would say campaign, fair, whether it's in hospital, school, or the mosque network. Okay, next. And in terms of the religious factors, they highlighted religion as being a source of strength, whether it's prayers, whether it's Muslim, Christian or Hindu. But beyond that, beyond being a source of strength in the Taman Medan, we find that actually the religious community or the mosque itself, the network of the mosque, in terms of the work they do, they're also providing the social protective mechanism in terms of the financial aid and whatnot. Yeah, and not just that, it would also be a very good place to actually reach out to, to the community, because when we spoke to the community religious leaders, some of them even have family with cancer, so they have actually been doing active outreach to the community on their own, which is why it was very easy, because of the way how well organized they were. They were actually the ones who provided with us with the cancer list of interviewees, as shared by Ms. Noor Husna earlier on. And religious factor, of course, also, in terms of accepting of the disease rather than denial, and how one could also be the chosen one, and also to provide one time to prepare for death, and as mentioned, the sin, but for others, who are we to judge? So those are some of the religious factors. Next one, please. Next, please. And in terms of the kind of support needed, so that to facilitate an early diagnosis, which is why the research is actually interdisciplinary, and as I mentioned earlier in my opening presentation, is beyond a biomedical, because which is why we explore the social, cultural, religious, and the social economic factor, because it's very clear they are the urban poor. So for the urban poor, financial support is very significant. And the reason why I highlighted the mosque as being the social protective mechanism, not just the mosque, even for for the Christian person that we interviewed, is actually the church people who provided active support. Even even in terms of food, paying monthly for food and whatnot. Yeah, so yeah, so the financial aspect is very important, especially for the poor, for the B40, and moral support, because cancer is actually will need moral support in the long term. And some of the things that was mentioned with regards to public hospital, the waiting time is long, and especially more so because we are doing the research during the pandemic. Yeah, I was saying even the time in getting an appointment is being delayed, right? And in terms of the support needed, also they also talk about, for some of them they mentioned information, that they also need more information about cancer, because when we discuss with them also, it seems that also for some, they are also not very knowledgeable about the issue, and also the significance of diagnostic tests. And going back to the kind of support needed, one thing that come across very clear, whether it's from with regards to the triangulation mentioned earlier, right? We hear from the community themselves, as well as the doctor. For the elderly, transportation is very important, because say once they find that they have cancer and they need to to go for further tests and whatnot, diagnostic tests and so on, or medical follow-up in the hospitals, if it's very far, it's very difficult. They will say, oh,
Dr. Lai, I think time is almost up.
Yeah, okay. Yeah, they will actually, yeah, okay, I'll wrap up. They will actually need to consult, to see whether there's someone to, to kind of send them there. So in terms of having to look at it in a holistic manner, those are some of the issues that would have to be looked into. Yeah. Okay. Thank you so much. I think.
Thank you, Dr. Lai. Thank you so much for your sharing. I think we will now go on to Dr. Muhammad Eshadul, who will talk about the legal protection and management of cancer patients' health data, Malaysia in Focus. So Dr. Eshadul is from the Faculty of Law. He and his student, Ms. Tilaga Ramalu, has been working on this area. You can share your slides, Dr. Eshadul.
Yeah, Prof, can you see?
Yes, thank you very much.
I'm audible, right?
Go ahead.
Thank you so much. Assalamualaikum, Bismillahirrahmanirrahim. Very good morning to everyone. This is Dr. Eshadul, and I will be presenting with my team member, Ms. Tilagavati, about our progress in this research, and we'll be focusing on the legal issues basically relating to cancer patients' health data, Before I start my presentation, I would like to thank Prof. Aisha sincerely for considering us for this project, because this is an issue which is really very important in the context of this digital world, where we have to share our personal information, and personal information is so important in this context, because without sharing personal information, you cannot use any IT related services. Digital world, I mean, we understand it or not, intentionally, unintentionally, we have been sharing a lot of personal information, and we really do not try, I mean, we being a consumer or from the policymakers point of view, we really do not see the fact that these IT companies, they have been using so many different types of tools to collect our personal information. And in that point of view, I mean, from that point of view, personal information is so important in Malaysian context. Malaysia is the first country within the ASEAN that has enacted the personal data protection law back in 2010. But unfortunately, after that enactment, and the law came into force in 2013. However, even after that enactment, we see that this area of law is still not progressing. I mean, in terms of proper implementation, and the regulators have been doing some work, and that is fantastic. We really appreciate that, but we feel that there are so many different things we can still do. Now, from that, I mean, with this, I'm really thankful to Prof. Aisha that from a faculty, from a medical faculty, she understood or she realized the importance of this personal information, protection of this personal information, and we were given this opportunity to contribute in this research. So, okay. As I have mentioned, that personal information is a must in this data-driven digital ecosystem, and this is somehow this is sometimes called as a gold or currency or the oil of the internet. And these terms are used intentionally because we are fighting for this term, fighting for these issues like this. This oil actually run the whole global politics, all these things, and these IT systems, they are collecting a lot of our personal information. We fully understand that these personal informations are very necessary in order to do research and all this development, because we have been encouraged to go for this evidence-based decision making. So we really need to share this personal information. Now, this personal information in another way is known as information privacy. And the privacy, as we all can understand, that this is so desirable thing for all of us. Privacy is good for everyone. Unfortunately, this privacy is somehow influenced by the culture of a particular country. Now, the challenge here is the law works within the national jurisdiction of a country, but the internet is borderless. I mean, for the internet, we do not have any jurisdiction. So sitting here in Malaysia, you can access to anywhere in the world, And because privacy is cultural driven, and we see differences of understanding in terms of privacy, like the North American, in the US, they respect privacy also, but they are coming from the capitalist point of view. They want to capitalize everything. Whereas Europeans, they respect individual privacy, and for them, individual right is very important, and they prefer individual right over community rights. However, in our Asian context, we respect our community rights first. I mean, the community should be protected, and in order to protect the community, we can curtail some of the rights of the individual. So you see these challenge. Law works within a national boundary. Internet is borderless, and we have these different approaches. However, ICT tools and services all are same everywhere. So you cannot simply say that a computer is made for this country, it will not work in another country. With all these challenges, different countries in the world, and when I'm talking about Asia, earlier we had this concern about Asian culture or Asian cultural practices, but now fortunately, China has enacted a new law, and I believe this will give a lot of hope to the Asian regulators. Now, the personal data protection laws are enacted to protect all this personal information which are used for commercial purposes. Now, this is a keyword. I will share later on about this commercial purposes. Let me give you a background of this personal data protection law. These are often broad principle-based legislation, and they regulate the life cycle of the personal data, starting from the collection, processing, using, storage, and use and destruction. So personal data protection law tries to cover all the stages of personal data, the whole life cycle. It gives the data subjects some rights, and it in line with those principles, and it considers some exemptions. Say, for example, R&D will be exempted to some extent. If data is collected by the government agencies, it will be exempted to some extent. Now, because we are talking about data subject and regulators, we need to understand that there are three main parties in this type of law. One is consumer, that is we and you and we, me, we have regulators, and we have some people, we call them data collector, and with them data processors. Now, healthcare industry is one of the most vibrant, commercially lucrative industries, and I don't need to explain it to someone coming from the medical faculty. You know, the pharmaceutical industries, and we have the volume of the pharmaceutical industries and the amount of money they are making and the investment they require. So we fully understand that these pharmaceutical industries need a lot of information to continue their research and development activities. And health is our priority. Health is priority for everyone. And that's why we have these insurance industries also. That industries also need a lot of personal information. And as I told you, internet and the ICT tools, that these work equally same way everywhere. And this is one of the main challenge or limitation of these third industrial revolutions agent, which is ICT, that the same software, the same tools can be used by a general, very ordinary human being like me. You can purchase a software, very cheap software easily. You can take some online services and you can be a hacker. And you can be you can do this kind of activities, unauthorized access. So you can break a security system of any hospital or this kind of thing. And after that, our concern is this ransomware issues. Ransomware is a issue where the people will be stealing all your personal information or relevant information, and they will be asking money for you. So these insurance industries, one concern we have in insurance industries, another concern we have these ransomware issues. Realizing all these things, and you know, health data is something you cannot change overnight. You can change your home address, you can change one house and shift to another house, you can change your religion also. But health data is something you cannot change. You cannot simply change your blood group, right? You cannot change your X-ray report. And that's why realizing the importance of health data, this data is treated as sensitive personal data, and it requires additional safeguard. Now, personal data protection law do not prohibit the collection of personal data. What it requires, it only asks for some additional obligation, accountability and transparency. Most of the people who are from outside the legal jurisdiction, outside the legal profession, they may feel that these kind of people, they always talk about this legal thing, staff thing, making compliance issues very defective, complex, and they will not allow us to survive, making life very difficult. But it is not. This personal data protection law, which protects our privacy, it is actually good for everyone. In many jurisdictions, the regulators come up with the guidelines, but in Malaysian context, we have not seen yet. In this context, the Rebung project, we are trying to explore emerging technologies to collect and process B40 female patients' health data. And because of the cybersecurity issues, because of these personal data protection issues, we really feel that we need to do something to protect the personal information of these patients. As you can see and explained by my previous speakers, that these people are already vulnerable. The way this is not a general disease, this is something life-threatening. And then there are issue of stigma, there are issue of fear, so many different kinds of things. And again, they will become a victim of this cybersecurity issues if their data are not protected. Already, we have seen many data breaches all over the world. I tell you that this lucrative part, and for all the used legal research methodology, which is sometimes boring for many. We don't have many exciting things to share like Dr. Lai shared. So we have used desk-based risk, and we tried to explore Malaysia's position and evaluate it with of some other developed countries like our neighbor Singapore. Due to COVID, we have been still trying, and we will definitely meet it before the project is final. So far, we have found this: our personal data protection law in Malaysia applies to private entities only, and the government is exempted. And because the government is exempted, the government has been collecting, or Ministry of Health, we know that there are many requirements that we need to fulfill. And once this private hospitals, they share this data with this Ministry of Health, then the data protection law will not be applicable. Ministry of Health back in 2017 introduced one system, Malaysian Health Data Warehouse, which is a very good initiative. We feel that it should be done, and it is in line with some of the developed countries. Interestingly, in 2020, the Clinical Research Malaysia, which is established by Ministry of Health, released a PDPA guideline. And to the best of our knowledge, this is the only guideline we have, which is actually developed by regulators. Now, after this COVID pandemic, this MySejahtera app was launched or introduced, and all of them, they are using all the three, they are using Malaysian PDPA as their base law. But the concern here is that this Malaysian PDPA is not applicable to the government agencies. So these are some of the concerns. Government is exempted from the PDPA. And this Clinical Research Malaysia's initiative is very welcoming, but unfortunately, nothing is mentioned about the legal implications, and obviously it is because the PDPA is not applicable to the government. The word commercial transaction, I personally feel that really creating a lot of problem, and because of that, people have been thinking that I am not doing anything commercial. So, for example, when government is collecting any personal information, because the government cannot make any business, so they feel that they do not use personal information for commercial purposes, and that is another reason why PDPA is not. I mean, in my personal opinion, is not properly implemented. PDPA is a concern because in this private healthcare sector also, in PDPA, there are so many different, I would say, regulatory mechanisms, but these private healthcare institutions, sometimes they do not know their obligations, sometimes they do not follow, or sometimes they have other priorities, they ignore this issue. We have studied some jurisdictions, Australia, Hong Kong, Singapore, and UK. We'll be definitely sharing this in our research findings. And as I was telling you, we can propose what Malaysian government should do, but at the same time, we understand this cultural issue, and at the same time, we understand our capacity or ability, or to some extent, government's priorities, because this is not very easy for a developing country or a country like Malaysia to follow some developed countries. But the government is doing something very good. Another interesting issue here is that the breach of confidence issue is legally protected. I see that this is a good sign. However, the protection of privacy, collection, okay. So the government is doing something, private organization, private medical healthcare service providers, they are still, I would say, they do not have any proper guideline, because the regulators hasn't shared anything so far. So what we feel that we should not wait for a massive data leak. As I was telling you, simply cannot change your blood group or X-ray. So we really need to do something very quick. Following others, we feel that the regulators like Ministry of Health, then MCMC, they should they should at least consider some exemptions, and they should at least consider these health data. If they cannot consider other type of data, other type of personal data for their exemption, they should consider at least health data. That health data for health data, they will follow PDPA requirements. The regulators should mandatorily, and this is very needed, that they should come up with some standards or guideline or code of practices for the healthcare service providers. Now, the regulators has already, as you can see, issued some code of practices for the aviation industry, insurance industry, utilities, banking, but health sector, very important, equally important for other industries also. And we do not have any code of practices, so it should be done very quickly. At least take some implementation initiative. So simple thing can be the government can simply check the websites of these healthcare service provider, because we already have some news of data breaches, so the government can ask for clarification what you have done. Most important thing is training and awareness. It should be it should be made mandatory that all these organizations should go for training and making people awareness. We have some specific recommendation to use cloud-based systems, and we have seen the practice from other jurisdictions. This is a good initiative, but as I understand that if the government make it a compulsory provision, then it has to be followed by all the healthcare service providers. A lot of money involved, and it may not be welcome, but at least the government can consider some initiatives. So moving forward, we will be drafting a privacy policy for the website of Robung, because we understand this is a pilot project and it will be in line with the PDPA and considering the international practices. And then we'll be developing the terms and conditions of the smart application, a mobile app, which Robung is preparing, and we'll be submitting our research findings for publication, and finally we'll be finalizing our report. Thank you so much. I will welcome all your questions. Thank you so much.
Thank you, Dr. Eshadul. I think we will take the questions right at the end, if you have time.
No
so
problem.
I think we better move on to the next speaker.
Sure, please.
Okay, thank you, Dr. Eshadul. So now we will invite Dr. Suniza to present on the development of primary care education for early diagnosis of cancer.
Give me a while for me to share my slides. Okay, my check whether my slide is
you can see your slides.
Okay, thank you, Prof. Assalamualaikum warahmatullahi wabarakatuh, and very good morning. Thank you very much, Prof. Aisha, for inviting me to be one of the presenter for our to present the sub-program for the Robung program. So I will be presenting about the developing a primary care education for early diagnosis of cancer. So basically, we are developing an online GP training for early diagnosis of cancer. Delayed presentation for cancer patient is always a major issue in treating cancer in Malaysia, in our population. In fact, in new statistics showed that 50% of breast cancer patients presented at the later age at the stage 3 and stage 4. With the COVID-19 pandemic, it caused a further delay the presentation. Not only the presentation, it caused a delay in terms of diagnosis and treatments. Thus, it results in the poorer outcomes of a patient or the prognosis of the cancer. COVID-19 pandemic also changed the way education and medical services are being delivered. We have no more face-to-face session as we have a pre-pandemic, and we are prefers to have a virtual web-based online training, for example, like we have today, as in a Zoom, as the platform of education, and it is more suitable and also safer. According to the World Economic Forum, the need for online learning and resources has increased tremendously due to the COVID-19 pandemic. So it shown that the online learning has promoted a learning and also information retention, and also require less time compared to conventional face-to-face learning that we have before. So to engage the community, the primary care doctors play an important role. So we have to the primary care doctors need to be equipped with an updated knowledge regarding cancer treatment, cancer methods of diagnosis, post-operative care, individualized patients' needs, and so on and so forth. Okay, so far the online learning platform is still limited in Malaysia, especially for the general practitioner training. So we are developing an online learning platform for the GP to explore the relevant updated evidence-based holistic management. This is why the objective of this study come about, to develop and also to evaluate an online training module for general practitioner. So the effectiveness will be measured by the pre and post questionnaires, which is designed specifically for this online GP training. The sample size of a GPs participating is calculated based on number of clinics from the unit Kawalan Amalan Perubatan Swasta, which located in the postcode numbers surrounding Taman Medan site. So the development of online GP training for early diagnosis involved 5 phases, which consists of 6 modules. So this is overview of the development of online GP training for early diagnosis of cancer. As I mentioned, we have a 5 phase. So the phase 1 is involved the GP training metrics development, followed by the module development in a phase 2. Once the module has been developed, so we will uploading into the open learning platform. And then we will test this platform, whether it's okay or not, in the phase 4 pilot testing. And once it's ready, we will roll out to Rebung, Taman Medan GPs, KK, and MBPJ clinic. So this is the pictures of us having a workshop training. For the phase 1 GP training metrics development. As you can see on your right hand side, this is the GP training metric, which involve a 6 module, and we have the Rebung GP training discussion among our community, and we do have an internal meeting in February last year. Okay, and this is the. On the 26th of September last year, we do have a workshop with a core GP training where we engage UMMC cancer specialists. So we do have a radiologist, oncologist, surgeon, physician, and also the GPs, and as well as the family medicine specialists from KK Taman Medan to involve in the developing of this module. And in last December, we do have eco immersion, and also we also engage the family medicine societies and MMA last year until March 2021, this year basically. So after we do after finish the phase 1, we do developing the module in a phase 2. And in the phase 2, basically, we done it somewhere in March last year until just recently, September 2021. As I mentioned, we focuses on the 4 common cancer in Malaysia, which is breast cancer, colorectal cancer, lung cancer, and cervical cancer. Okay, we are not only focusing. So what interesting of this module development is not focusing on the disease. We also involve the role of GP in a module 5 in a cancer psychosocial support and navigation of patient for cancer early diagnosis and screening and survivorship care. So interestingly, we also involve some of our cancer survivor in part of this module. So we find the fact on national guidelines as well as evidence-based literature, and we develop through a mapping with a learning objective and with help of Haji Norashimi bin Saad, who is the senior lecturer from the Department of Curriculum and Instructional Technology, Faculty of Medicine, Faculty of Education, University Malaya. We develop online GP training based on these 9 events of structures. Of instruction. So this is a Garnier 9 events of instruction is actually developed by the Robert Garnier, who is educational psychologist, who created a 9-step process called the events of instructions. So this 9 event helps trainer and educators as well as the instructional designer to structure their training session. And it also help in terms of the model is very systematic that help us to develop strategies and create activities for instructional classes for this online GP training. Not only that, we also use Kirkpatrick's 4 levels model, where this is for evaluating the results of training and learning program. So it assesses both formal and also informal training based on these 4 level of criteria, which is one is reaction, and we see what did the learners feel about the learning experience, and the two, did learners actually learn anything? So, and the third one is did learners actually do anything different from this GP online training? And last but not least, what was the effect of this training to their practice? So many trainers use this Kirkpatrick model backward as a guide of developing effective training as what we are developing now. So that is phase 2, and now we are at the midst of phase 3. Basically, we are uploading whatever the content expert into the open learning platform. And then this open learning platform, we choose after we engage with Dr. Vinodini Vasudevan. She is the instructional designer and working closely with ADEC So during the meeting, we identify what is the suitable platform and what is the suitable course for massive open online course, and we also plan the mapping based on the platform requirement for the online GP training. Okay, so we are still in progress of phase 4. Once the open learning is ready, so we will do a pilot testing the online platform to the GPs probably in end of December, and we will edit it and modify according to their review and also the comments by GP, either the medical officer or family medicine specialist from KK Taman Medan. And last but not least, the phase 5 rollout the online GP training. So basically in the phase 5, it means that the open online learning is ready. Open learning is ready. So we will roll out to Rebung Taman Medan GPs, KK and also MBPJ clinic for a 6-week course with actually 1 hour course for eco immersion to ensure that the GP knows how to use the online training. And we divide them into 2 groups, and the study group is basically will receive the online training for 6 weeks, and we will assess, we will give the pre and post intervention questionnaire based on the knowledge, attitude, and also the practice questionnaire. We are planning this somewhere in January or February next year. Hopefully we can settle this as soon as possible. And last but not least, to evaluate the impact of this training, we will prepare the, as mentioned earlier, we prepare the questionnaire pre and post, and we will analyze in order to write up for the publication. I think that is my last slide. With that, I end my presentation with thank you.
Okay, thank you, Dr. Suniza. That was a very nice short talk. Just to share with you, I think we do have people from Klinik Taman Medan. Dr. Vicky is here. Dr. Nur Saleha from Ministry of Health is here. So we're happy to invite and have all our stakeholders to listen to the updates. We haven't met recently, I think because of the COVID, but these are mainly updates from the Rebung team. So now I'd like to invite Associate Professor Dr. Hairin Hadi, who will now talk about developing the Community Navigator Education Program for Rebung. Dr. Hairin?
Okay, Assalamualaikum. Thank you for inviting me to present this. Let me share my slides first. Can you see my slide?
Yes, we can.
Okay. So I will be presenting the subprogram 4, another section of subprogram 4 in terms of developing a community navigator training program. So basically, the objectives of this subprogram is to develop and evaluate the online training module for our community leaders. And it focuses on 2 sections, which is the knowledge, the signs and symptoms of 4 main cancers that has been mentioned before, the breast cancer, colon, lung, as well as cervical cancer, and also investigations for screening and diagnosis of all these 4 cancers. And the other factor that we will be putting in the training module is the navigation process of where the community can go for screening to get a proper diagnosis, and also how they're going to be managed as a person under investigation for diagnosis purposes. The other navigation that will be included will be the financial assistance if the individual need to, and also where they can get psychological support. We will be doing the pre and post evaluation of the training module in terms of effectiveness in gaining knowledge and in the 4 main cancers, as well as the navigation processes. It is also very important. One of the objectives of this is to ensure that the current training module is sustainable even after the grant has ended. So this is where I am, the subprogram 4 amongst the other subprograms of Rebung, and it focuses on the community. And the development of the training module starts with fact-finding from national guidelines of all 4 cancers, and also evidence-based literature from previous studies on why individual come in late for diagnosis or screening, and also the previous projects on effectiveness and delivery of cancer projects in the past. And the main feature of this training module will be focusing on the content and the hooks that we are going to incorporate in the training module. So based on the subprogram 3 communication, Dr. Lais, later on Hikmah and Dr. Yukong, and also Dr. Lais project before. So we have the communication with the stakeholders from the community. There were interesting factors or barriers and facilitators that we have that they have identified, which surrounding the cancer. For example, black magic as a cause of cancer, bad karma that they have done before that causes that cause them to have cancer, and that nothing can be done once the diagnosis of cancer has been made. And this also the perception of talking about, for example, breast as something which is sexually related, and that people do not want to talk about any changes that happens to them, for example, on the breast, and also if there is any changes, in their bodily function that can be perceived as sexually explicit, that deter them from talking. And the fact that the previous campaigns or awareness project that has been done before put cancer into a very negative note. For example, like people get depressed, people with depressing pictures surrounding cancer. So we want to give a lighter but positive note that this training module will feature. The content has got to be concise and easy to understand for this community, and the use of infographics so that it gets the audience to have a mental picture of how things are going to be done. For example, how to do breast examination, assessments of stools, for example, and also the investigations that is going to be done onto them, or how it is going to be like. It is one of the things that is important is also to emphasize the importance of early detection and diagnosis, and that asymptomatic individuals need to go for screening. Before this, perhaps some individuals think that they have got to look for signs or symptoms, only then they need to go to see a doctor. But it is important for us to emphasize that even if they do not have any signs and symptoms, they need to go forward for screening, and that's the whole purpose of screening. That everybody is at risk, and early intervention is very important because something can be done about it, and not everything that they found abnormal on the body must be cancer. It may be something else, And we also have a tagline of badan kita mestilah jaga, to reinforce self-care in the community. And the roadmap and directory is going to be in the content of the training module as well. So to facilitate the navigation, if the community individuals need further medical input, for example, from the NGO, from klinik kesihatan, their GPs, and also financial assistance either from the government or NGO. So we are going to do, we are going to go into an online, for as mentioned before, that because of the pandemic, COVID-19 pandemic, it needs to be evolved into from the traditional way of delivering education face-to-face into online version. And I think from the GP side, it is on Zoom, but from the community, we are going to put it up on 12 short videos, which is this one. It basically for main cancers, the introduction of the cancers, what they need to know on the signs and symptoms, and what investigations, and also how to navigate them for further information and investigation. So it is going to be something like very light and something relatable to them, like simbang apa tu badan kita, kitalah jaga. So so all this information that they need to know, that it is very important for them to come forward. So as mentioned before, so it is going to be online version, 12 short videos that we are going to deliver to them. And we are going to use EPPM framework, which is extended parallel process model, which emphasize on the high in fear or threat of the message, but the self-efficacy messages has got to be stronger, meaning that they have this fear of what's going to happen to them, but they will come forward to get something done about the condition. So the development team of the content includes medical experts from 4 main cancers, breast cancer, colon, and such, and the stakeholders from the community, designers to design the design and also develop the videos that we are going to do, and also expert in community communication strategies, and also a creative producer as a script doctor for the content. We also collaborate with designer for Know Your Lemons. I think a lot of people have heard about it. This is one of the things that we want to incorporate, that, when talking about breast, because it was sexually related to related. So they, this designer has adapt, a lemon as a way of how to describe the changes in breast. So we have get this as a reference of how to deliver the information to the community. And as a we also use the service of celebrities to entice interest for them to look at our videos. So we are in the development of the videos as we talk. So the training is going to be sometime end of November. So the recruitment of the community leaders mainly from the previous engagement programs like Keluarga Sihat 50, Pusat Daya Wanita, Berdaya Wanita, and also we are going to evaluate the effectiveness of this program with the pre and post evaluation in terms of knowledge and barriers to diagnosis, and also navigation processes. So we are going to start with the pilot training with the first video, the colon, which is still in the process of development at this time. I think that is my last slide. So I welcome any question if you like. Thank you.
Okay, thank you, Dr. Irene, Prof. Irene. We will take questions right at the end. So we'll let Hikmah and Dr. Lee present the next section, then we'll take questions at the end. Thank you. So Dr. Lee or Miss Hikmah?
Hi. Okay. Yeah.
Okay, all right, great. Go ahead.
share this screen now. Okay, so very good morning, everyone, and thanks, Prof. Aisha, for inviting us to present on subprogram 3. You probably are very familiar with this subprogram. Let me just turn on the. Yeah, can you share the screen? Thanks, Sigma. So it's wonderful to go last, because I think I've attended the whole session through and just seen how massive the Rebung project is, and a big kudos to Prof. Aisha for managing the whole team very well. So for this last one, it's actually the title of our subprogram 3 is a health communication campaign on awareness of early cancer diagnosis among an urban poor B40 setting, using the community-based participatory action research approach. So I think I'll be presenting as the PI, and then as I mentioned, Prof. Aisha is very involved, but also I think a lot of credit goes to Hikmah, who has actually done a lot of work on the theoretical foundations of the CBPAR approach. So I'm just going to give you a quick overview of what we're going to talk about. We're going to try and give you an understanding today of how we've come to understand the CBPAR approach. It's a very interesting approach, I think, because it contrasts quite differently with the way I've done a lot of my qualitative research, and I myself am learning a lot from just the philosophies of CBPAR. I think we also give you a snapshot of the subprogram 3 so that you can see how the CBPAR approach informs the development of a health campaign for the community. And lastly, I thought it'd be nice if we just hear some reflections from myself as a more experienced researcher coming to a new approach and trying to learn by contrasting it with my experience, but also from Hikmah, who is doing her PhD on this subprogram, and her perspective as a novice or fresh researcher, and the insight she has is also very helpful. Let's go to the next slide. So what really is this term, the CBPAR approach? I heard so much about it when I was undergoing my PhD as one of the methodologies, but it was never really clear to me what it was. So now it's my chance to get my feedback. It's not so much a methodology as a collaborative framework that really aims to develop partnerships through the research process to achieve some kind of behavioral or social change. So there's that element of not just collecting data from people and reporting it, but actually working with them to achieve a kind of change within their own community with the community members. There are 3 key features of the CBPAR approach. And these are, the first one is that it blurs the distinction between researchers and research participants. I myself come from my main discipline is shared decision making. And I think there are parallels here for what the CBPAR approach did for research with shared decision making. So in shared decision making, it contrasted with what was termed a paternalistic approach to medicine, where instead of the doctor deciding as an expert what the patient should do, in shared decision making, they recognized that the doctor maybe had the medical expertise, but the patients had the personal and local expertise. And both were considered experts in the process, and both came together to share and develop decision making in a consultation. I think the same parallel process can be applied to the CBPAR approach for research. The academician has maybe perhaps academic or theoretical expertise, but it is the community member who has the local or personal expertise, and they come together as equal experts and share and develop a joint research process together. The second one is that participants are not passive subjects, but become actively involved in the research process. I just want to share a bit of background about Hikmah and myself. We're both from a psychology background. In relation to this, I think it was very interesting that in the early 90s, the British Psychological Society actually said that they wanted psychologists to, the society recommended that the term subject to refer to participants in research be abandoned and replaced by the word participant. And that was in the early 90s. And in the mid 90s, Ian Chalmers, you probably know him as the founder of the Cochrane Collaboration. He started to advocate for this in the medical community as well. He said you should do likewise starting in the mid 1990s up until the late 90s, you could find him writing in to journals to do so. So this shift happens in CBPR as well, where instead of just moving from the word subject to participants, they are actually participatory. So they become full active members in the research process. I think the third one probably answers the question that I had. What is CBPR? Is it a research methodology? In the sense, it doesn't really define the methodology that you have to use, but involves certain elements, and these are the key ones: repeated episodes of reflection and action by a group of peers or co-experts until problems of importance are solved. So it's got a general definition, and perhaps two elements that we need to keep in mind with CBPR are reflection, thinking about an issue, and action, either creating or doing something about the issue in an iterative manner until the problem seems to find a solution. Let's go to the next slide. So why bother with CBPR? So a knowledge gap exists, and CBPR really is a way to construct new knowledge based on a bottom-up or ground-up approach instead of a top-down approach. And it really is a way to idealize community-based solutions within a person's community. I also have been doing a bit of research in another field called implementation science. And what is interesting is that implementation science also has this approach where we have to work with participants on the ground. But interestingly, when you look at the literature around how you develop strategies, very often the development of a strategy in implementation science depends on the expert or the academician running the research. So it comes back down to the I'm the expert approach to deciding on strategy, even though the initial exploratory approach may have been done with participants. In CBPR, it is about community-based solutions. So it actually incorporates another element besides the theory, literature, and expertise of the academician. It incorporates the element of the community very strongly into the research process. Next slide. I think let's look at a bit of the literature, and this one I'll hand it over to Hikmah to present on where we are with CBPR.
Okay, thanks, Dr. Yukong. I'm actually a bit nervous for this presentation. Okay, thank you everyone for being here. Thank you, Dr. Yukong. I'll just continue on about the research trend then. So CBPR has been used in the health settings to address health inequities of minorities such as, the ethnic and socioeconomic groups. So this helps us to increase the research relevance, applicability, and also the use of evidence-based interventions across different settings. Okay, so CBPR involves the research team and also the stakeholders like Dr. Yukong mentioned earlier. And the common framework to this is usually you'll see the project design and implementation, the partner engagement, data collection, feedback and interpret findings, and then the dissemination and the translation of research findings. And what's not here is the maintaining and sustaining and also evaluating the partnership. Okay. So we are the Rabong Subprogram 3. What we're doing is we're trying to address the communication barrier to the early cancer diagnosis in Taman Medan. So our specific aim is to develop and pilot test a health communication campaign focusing on early cancer diagnosis using the CB-bar. Okay, so there are 3 phases to this project. Phase 1, which is the community engagement. Phase 2, campaign design. And then for phase 3, we have the campaign pilot and evaluation. We actually just ended our phase 1 about community engagement. What we did was individual interviews with the participant from Taman Medan to explore their communication in terms of early cancer diagnosis. So we asked questions, for example, about who are the people responsible to disseminating information or resources to the people in the community. So that happened in phase 1 to engage them individually. And then for phase 2, we are currently in phase 2. We are developing the campaign. with the community. So when I say campaign, it's not just, you know, like a physical campaign that you set up a tent and then you invite other people. So campaign here can be defined as the messages and the channels and also the implementation work plan that we are developing with the community. So we are using the nominal group technique to develop the campaign with the community. And then, like Prof. Aisha mentioned way earlier, we're going to be having the campaign pilot in February next year, along with the evaluation. Okay. I want to highlight that for phases 1 and 2, we've been interviewing or interacting with the participants online. So for phase 1, since it was individual interviews that happen via phone calls or video calls. And for phase 2, this is an example of how we are doing our phase 2. We are meeting with the participants on Google Meet. Like I said, phase 2 is about developing the campaign with the community. So this is how the meetings have been going on, even though we haven't been, you know, seeing them in person, like how subprogram 2 managed to do somehow. This method still allowed for dynamic and engaging conversation. Okay. So a few lessons that I learned from this project so far is that, especially from phases 1 and 2, it's very important to identify the participants for the participatory component, because you do want the right people to be involved, because you know, these are the people who would have the insider knowledge about the community practices, the nuances. This would help everybody to have like an aligned vision, especially about things that matters the most to the participant and their community, on things like early cancer diagnosis, right? And then since we've been meeting with them online, it's very important to not just engage with them during the meeting, but also before and after. What I mean by that, it's very important for you to regularly engage with the participant over text, or sometimes they will call you. So you have to be responsive when that kind of things happen. And it's basically to let them know that we are there for them and that they can, you know, trust and work with us together. And then for tokens and incentives, it's also very important to you know, compensate them with their time, their energy, and then also some participants, you know, they use their phone data for for meeting us. So that's very important to highlight that too. And then I think for the next part would be you, Dr. Yukong. Thank you.
Thanks, Hikmah. So Hikmah is sharing. She's been the primary person engaging in the community. And I've joined a few sessions, so I just have 2 reflection points that I think have stood out for me in this process of trying to develop a community-based campaign. So the first one was actually in phase 1 that I took this phrase from one of the earlier slides: people who care enough about the issue. And what I've been challenged to do is actually think about my prejudices and biases when it comes to B4D community. And I must be honest and say that I thought that perhaps it would be hard to engage them. Perhaps they would find it difficult to respond to some of the questions that we asked. But what I found, and I've been totally changed in my mindset, is that they are able to contribute vocally. They are very clear about what the community needs. They are able to contribute honestly. They are not, when the approach is done right, as Hikmah has mentioned before, they are open to share what they feel and what they are afraid of, and what are the things that are concerning, or the things that they are unsure about even. I think they're also able to contribute meaningfully. There's a rich description of cancer messages. I wish we could share some of the preliminary data from phase 2, where you would see that when we ask them, what is it about cancer, certain types of cancer that scare you in community, the level of detail that emerges from the written messages that they write down on a piece of paper, take a photo of, and send to Hikmah through WhatsApp. Those messages are very rich, very detailed for many of them. I think the second one that I realized is actually that that this process of working with a community requires maybe 3 or 4 stages of adjustment. It's very different from my previous research experience, research process. So the first phase is this openness or curiosity. I think for the researcher, it's really, for me, was what is CBPAR? What is this term CBPAR? And how does it work? I think for the community, it was when they agreed to join us on this CBPAR project, it was agreeing to something new, a novel experience. A lot of them, some of them in phase 1 mentioned that the experience with past research was always very rushed. It was them coming to the hospital and someone approaching them and saying, can you fill this, help me with this research, in trying to squeeze in the research within the rush, the hustle and bustle of hospital visit. And this is a different kind of research, going out to the community and engaging them where they are. I think there's a bit of hesitancy. I think for us, as Hikmah mentioned, it's always for the researcher is logistics. Perhaps there's a loss of a control environment because you're working with people who whose lives are actually quite challenging, quite unstable sometimes. Some of them send Hikmah a message and say, I'm in a hospital right before the meeting, and send her a photo of themselves in the hospital to prove that they couldn't make it. I think for the community, there's a lot of hesitancy because of, number one, environmental constraints. We've had people drop in and out of calls, or as I said, their timetables change halfway. I think the second one is actually what I've actually been quite sad to see is sometimes there's a bit of an inferiority complex. Like, why are you coming to me? Shouldn't the Ministry of Health, shouldn't the university know how to do this better? And we have to reassure them, no, don't feel inferior. You are the experts. I think the third one is participation. It's when you see the partnership start to flower. The researcher is designing a methodology, as Hikmah mentioned. She has worked out the NGT is what she wants to use, and she's adjusting it to the locals' rhythms. She has to adjust between trying to get them together as a group, trying to manage that. Sometimes there's a lot of community events. There's Deepavali, there's a wedding happening. So always adjusting to their schedule. I think for the community, you can really see them when they participate in sessions. It's two things. One is academic. They are keen to contribute to the research question, to the research process. But I think they're also keen to contribute socially. You will see them very quickly. They've not met each other before, but they interact with each other as if they're old friends sometimes. And lastly, I think the last stage, hopefully we're getting there in towards as we come into phase 2 and phase 3, is that there's a partnership building towards the goal of having research that's relevant, that's applicable, and that has a strong use of evidence-based theory and evidence-based interventions in the Taman Medan community. So I think that's all I have to share.
Thanks, Yukong. That was really nice. And Hikmah, I think you also reflected a lot on what you're doing now. Can we all have the panelists to switch on your videos? And maybe we have about 25 minutes to maybe answer some of the questions that's in the chat box. So before that, maybe I'll just share the multi-sectoral thing that we have so that we have a clear idea. Oops, that's the wrong one. Let's see. Oops, sorry. Okay, so before that, maybe Dr. Lai, do you want to take the question that was asked earlier about the method that you use when you engage with the community?
The earlier question, I think I've answered some of it. I think when we engage with the community, that's one thing I've learned. Patience is of utmost importance. Yeah, because if some of them is very quick, some even because of the incentive, and we understand, which is why we actually have the RM50 ringgit incentive, because it's time of their work, right? Yeah, and it's also, so that helps. But on the other hand, patience, I would say patience over and over again. And because also sometimes they say they agree to a time, but then, they will reschedule last minute. And sometimes they don't even tell you, there's also been cases where it's that, but we were both Husna and I were persistent. We actually, contacted them again and again. And one person, I think over 2 weeks. And then finally only I was able to, to interview the person. Not just that, it's also like suddenly, hey, I'm free at this time. Say we agree at 5 or 6, but suddenly the person say I can't. And then she said maybe tomorrow. I'm like, okay, tomorrow then. But suddenly 7, as I was going out for my evening walk, because that day I happened to want to go at 7, she just called, can we do it now? So it's like I had to drop everything because I was like, okay, this is very important to me. No matter what, I had to drop everything and say, okay, give me 5 minutes. I'm going out, to do the interview. So yeah, so it's persistence, and it's also patience, yeah, and to try and to be understanding, because sometimes they say suddenly my boss asked me to stay for 2 more hours, so I'm sorry, I thought I could be back home, that was what she told me later, yeah. And besides that, I find that
so I think it takes a lot of patience. I think also mentioned, right?
yeah. And
so
besides that also, Prof, can I just add one more? I think there's one more thing that I wanted to add. It's also during the interview process, I think it's also very, besides that, one has to be very persuasive. I think a good interviewer is actually one who can persuade someone who's unsure, but to convert it into a yes, I'm going to go to the interview. And I think one thing that I've learned over the years is actually to assure them how important their sharing is to us, not just to us, the researcher, but also to improve, in this case, of course, the survivorship in the long term. So I think that's that's very significant. Anyway, maybe Husna also have something to add, but to the.
Okay, Husna, do you want to add on anything from your experience? And I think the going out into the community is extremely challenging, but you all managed to do how many? Can you share how many patients or how many people in the community did you interview in the course?
So far we have 53, but I myself, I interviewed almost half of it, or like almost 30, yeah. And during my first visits to the houses, this was before the MCO. So Dr. Lai actually accompanied me to one of the physical interviews. And then after that, Dr. Lai just let me do it on my own. So the days that I actually went to their houses, visiting them and all that, it actually, like for me, it was like a very beautiful experience because I am a stranger to them, but the moment that I knock on their doors, they just like, oh, apa ni, you're from the UN, the project, oh, come and like into our houses and all that. And then like during the interview process, it's not only me interviewing them, it's also me talking to their other family members. And then sometimes they will macam hidang makanan ke hidang air, and then it's a beautiful process of getting to know the families and the community better lah. Yeah.
Yes, and I think the study that you did with Dr. Lai and team is really wonderful because it really helped inform the campaign itself. There is a question about how we can improve self-examination, and I think specifically for breast and testis cancer, testicular cancer. Maybe Dr. Haireen or Prof. Haireen or Dr. Suniza, anyone would like to take this question? That how do we improve, how do we encourage them to do more self-examination?
If I may add on a little bit on that information is that perhaps the information of how to do it, that they probably need more structural or information how to do it and when to do it, and if they don't know, that there is a channel for them to ask, for example, that in the clinic kesihatan or in from the GP. And it is also part of the community module, training module, that we want to tell the community leaders that, if they disseminate information to the community, they can actually contact the community leaders, and community leaders can actually navigate them to get more information of how to do it, for example, to NGOs, GPs, and other places that is that is available for them to gain more knowledge about it.
Yeah. Dr. Suniza, any comments?
I would agree with Prof. Haireen, but for my experience of seeing patient, because I'm a breast surgeon, we always encourage every single time we see a patient for them to do the breast self-examination by their own, and as well as to encourage family members. So I hope that with that, at least for the small step, at least can help others to learn how to do it, breast self-examination. But Most of them, they say that they are not sure how to do it, even though they already had like 10 years survivor, breast cancer survivor. But still, as a doctor, we are still play an important role to encourage them and educate them how to do it. That's an important
I think
message.
what you mentioned about confidence level is one of the issues, right? They all feel they are not confident with detecting the signs and symptoms. So I think what we have sort of brought to the table are innovative methods of educating on breast health. So like the Know Your Lemon. So those are just using visuals to teach people how to identify symptoms. You can actually go to the website, it's actually there, Know Your Lemons. And we did a study about 2 years ago because of the pandemic. It's currently being sent to journals and all that, but not published yet. But essentially, women felt more confident in detecting symptoms of breast cancer just by looking at the lemons poster, because it sort of gives information about 12 types of symptoms of breast cancer and also what to feel, how to feel. Is the lump hard, soft? So you can get that information from the website. So maybe I put up this slide so that you can see that each of the sub-programs are coming up with their little packages for the actual campaign in between February to March. And I think there was a question about how we can work together and how we can involve Ministry of Health and other NGOs, how we can actually get everybody together. So I think the massive part actually about Rebung, and I think we spent almost a year engaging, and even now we are still short of some very important meetings with the major stakeholders to ensure that we can build a sort of environment where we pool all resources, because right now we have multiple cancer NGOs that go out to the community, and they have done a great job actually to help educate the community. But somehow the non-cancer NGOs, they tend to not know much about cancer, and people shy away from cancer. So in a way, what we're trying to do is to get the non-cancer type of NGOs and groups to learn more about cancer so that they can also contribute to the cancer control. So you can see that the key stakeholders and the research beneficiary of this study is really Ministry of Health as well as the Selangor State government, because we realize resources are aplenty. Well, not really aplenty, but there are resources even with the Selangor State government, because they do have programs like, for example, free mammograms, biopsies also for women in Selangor, and yet we are not able to get this to the community. So I suppose the training, you can see that the packages is the campaign, the training, the 2 trainings that we will be doing that will help to accumulate to some sort of an output. And we also work very closely with Ministry of Health, because we are actually collecting data that has been collected with from the Ministry of Health point of view. They are collecting like how many people come forward for clinical breast examination, and we actually have many women having clinical breast examination, but unfortunately only about 7% of those women are more than 40 years and above. So we hope to try to find ways to get the right target people to be screened with clinical breast examination. So you can see among the NGOs, we have National Cancer Society, of course. We have Breast Cancer Welfare Association, Hospice Malaysia, because we found one of the major issues faced by this community is advanced cancer. And we do not want people to suffer, at home without any support. So we managed to get Hospice Malaysia, and they actually do support this geographical location. The other organizations like CORUM, that is the Colorectal Cancer Society, they are also involved with this project. We have the Lung Cancer Network. We also have Pusat Wanita Berdaya, which is actually the women's arm under the Selangor State Government. And of course, we have the Keluarga Sihat 50, which was initiated by Prof. Adiba and team from the Social Preventive Medicine, where they have trained 2 cohorts of 50 families on how to live healthy lives, how to cook well, how to exercise. So this is a ready group of women within Taman Medan that can be educated about cancer. So I'm not going to say too much, but essentially it is a complex intervention. And I think without the help of everyone, you can see how many people are in this team. And we are hoping that we will produce a pilot, a sort of something that can be used for future locations and help to improve the evidence for cancer control in Malaysia. So maybe before I think we have about 10 more minutes. Anyone would like to comment? Maybe on the, because Dr. Suniza, she sees patients, right? And we see patients from Taman Medan. Maybe some reflections as a doctor, working in the clinic and seeing patients from this part of our neighbor actually. They're very close to us.
I think from my experience, what we can see, even though Petaling Jaya so-called urban area, but we still have received a patient with presentation, a late presentation, you see, like stage 3, stage 4 disease, and it's already like once they presented late, so the in terms of treatment will be complex, and if it's stage 4 disease, is more towards like not for the curative, it's more like a palliative intent, and then to prolong the survival instead of like a curative. That's why we hope that by engaging the community, they can come forward, and then at least we can get early cancer diagnosis as what we are trying to do. That is basically the aim of this project, basically. Yeah.
Yeah, even for example, the national and state programs that give out some form of financial aid is not well known among people from the B40 community. So isn't it, Suniza? I mean, we see that a lot in clinic, right? They don't even know about it. So,
yeah. Like we have the My Salam. See, the My Salam is meant for the B40, BSH, whoever that receive a BSH, they can apply for My Salam, but apparently it's meant only for the stage 3 disease. Yeah, so whoever that not stage 3 disease, they have to apply other resources. Yeah, but we do have a zakat makna, and that we can actually help the patient to whoever that had a financial constraint or financial issue. Yeah.
Yes. So
if I may add a little bit more, I remember one patient that I saw who came in quite early with stage 1 breast cancer, and then she was lost to follow up. And when she came back to the breast clinic, she was, the cancer has been fungating and all that. And I don't know whether you remember, I saw it with you, Prof. Aisha. So basically what happened is, like, when they go out to the community, they are involved with other family members and friends perhaps. She went out to get other types of complementary treatment. But this is the most important thing, that we need to perhaps engage the community leaders, that they will know this, they might know these people, and they are the ones who can actually help to navigate this patient of where to get help, because they might some patients might not be comfortable talking to doctors yet, so they do have people around them to talk to and to advise further, for example, navigate them to NGOs, to a person who already involved.
Yeah.
Hi, doctor.
Hi, sorry. Wait a minute.
I cannot see you all because I'm showing my slides.
Yes. To engage other the people in the community to get more information, probably guide them to the facility or resources that are available for them to get information and be guided before it's too late.
Yeah, the key, I think, is really the information. I think a lot of people do not understand the health system. They may be seeing the wrong doctors also sometimes. A lot of our breast cancer patients sometimes see gynecologists, and some gynecologists may even remove their lumps. Okay, so there are many issues with understanding the health system. We see that a lot in our patients. So within the project, if you can see, there were packages that each of the subgroups will prepare. So one of the things that we will prepare will be this cancer care navigation handbook that will be made for the general practitioners as well as for the community navigators, so that they understand the health system better and they know where to search out for subspecialist surgeons or other people. For example, they wouldn't know there are actually respiratory physicians out there that they should see, and for the GPs to refer to. And I think we all talked about many things, and you can see how Dr. Eshadol is a very important part of this project, because if you were to navigate people across the different healthcare facilities. So for example, you're seeing someone in the GP seeing someone, and can she refer that person to another facility and provide the name and all the identifiers. So I think one of the important things that we hope to come out of this is by producing a requirement specification document that can assist us in developing future apps that can be placed in the super apps that the government already has now. I think we're looking at things like My Sejahtera. I mean, why not, having a cancer navigation tool to help people navigate the very complex, pathways would really help, I think, people in the community. And furthermore, the legal aspects is usually not well understood by our medical fraternity, because we cannot really send our, like what we do all the time, we send out information to our colleagues and all that. There are issues related to the legal aspects of that. So we hope that the policy, when we get the policy paper written up on how we can share this information, that will guide us in the future how we can develop a navigation tool for this community. So I think we are almost ending in about 10 minutes. Before we end, before everybody leaves, I'm not sure Dr. Lee may have left. I think we should take a photo, like all Malaysian Zoom, we should take a photograph so that we can document, especially for our impact interdisciplinary research grant. We need to show that we have been here and we have done this workshop. So can we have all the cameras on? We'll take a photo. Can you all see? Can I ask Hikmah for your digital native skills?
Maybe you want to unshare your screen for a bit.
Did I unshare? Oh, wait, let me unshare. Okay. How do I unshare? Did I unshare? Okay, thanks. Okay. I don't think we have any other questions. Did I miss any? No, right? Okay, so a lot of hard work and more hard work until May next year. So thank you so much for your commitment, your dedication, okay? So we'll see each other again 13th November, where we're inviting all our stakeholders. And I'd like to record our gratitude for all our stakeholders who are actually listening in. We hope to bring you more information and interact with you on the 13th of November this year.
Thank you.
Thank you. So I'll pass over this to Dr. Sharifah or Dr. Syed to maybe introduce the next session. Or I think Prof. Sarinder is already here.
Yes, good morning, Prof.
Hi, you're already here, right? You have about 5 minutes, but maybe you want to use that time to introduce and all that?
Yeah, okay, no problem.
All right. Okay, thanks everybody from Rebung. We'll see you all on the 13th of November. Okay, bye-bye.
Okay, bye.
You can stay back, for the next session. Okay, bye.
Take care, Prof.
Okay, bye.
Take care.
November.
November, don't forget.
Okay, good morning, everyone. I'm Sarinder, and I'm from Faculty of Science. I've been engaged in the breast cancer research, mostly designing systems, computer systems, data science systems, data analytics, and also at the moment we are working on a very important project, which is Journey for patient. It's a patient navigation app which will be presented by Prof. Aisha later in the second session, which will start shortly. So I think this is a very important topic, research topic that we actually engage different people, different research areas into coming up with or producing systems that could improve the survival of the patients. As we know that the survival of patients, of breast cancer patients in Malaysia compared to the developed country is pretty low. I would say that, you know, if you compare to countries like Europe, or, you know, continents like Europe or America, the survival of patients 5 years or even 10 years is quite high for non-metastatic cancer. But in Malaysia, I see that compared to these countries, in Malaysia, the survival of patients is pretty low. So I think it's about time that we work on this area and try to improve and produce factors, or come up with factors that could improve the survival of the patients, our own patients. And today we have very good speakers who will be talking about different areas for breast cancer survivorship, starting from the MyBCC project, which has been actually for many years. Dr. Tania Islam has been working on this project. So today she's going to share with us about it's about time that we actually conduct a well-coordinated survivorship care for using the MyBCC study. And total we have about 6 speakers today, and we will hear from our experts, and then towards the end we will conduct a discussion Q&A session. So it's good that if you can stay with us throughout the session and listen to our experts. Also, you can also join in our research teams if you have very good ideas that you can, you know, share with us and improve the overall survival of our patients in Malaysia. It's without further ado, maybe we should start immediately, as sometimes we will, the time frame, the time for each presentation might not be enough, because 15 minutes for each presentation. So we will start with the first presenter today. I can see that Dr. Tania is already here, and she's excited to share her presentation with all of us. And, I will let Dr. Tania introduce herself and also introduce the MyBCC study to the audience. Dr. Tania, can we start now?
Yes, can I share my slide?
Yes, of course.
So, good morning, everyone, and Assalamu alaikum. Thank you, Professor, for inviting
Yeah. Maybe you can, sorry to interrupt, maybe you can zoom out a bit.
The slide, right?
Yeah.
I actually...
It's just my screen. Maybe you can continue. I think maybe it's just my resolution. All right, you can continue. Sorry to interrupt.
Is it okay now? Because I entire screen I share.
Yeah, I think it's okay. Yeah.
Okay. Today I'm going to talk about the Malaysian breast cancer survivorship cohort study and how actually the finding of this study led us to a well-coordinated survivorship care. My BCC cohort is the hospital-based prospective cohort study. We aim to recruit actually 1,000 patients newly diagnosed who are managed in the UMMC, and we started our recruitment since 2012. Still, we are recruiting. We are almost there. In our cohort, actually, we include all the women who are newly diagnosed with primary breast cancer patient, who age is 18 years and above, and within 4 months of diagnosis, and the TNM stage should be 0 to 4. And only we recruit patients who are Malaysian and able to converse either in Malay, English, Mandarin, or Tamil. And we exclude patient who has any prior history of any cancer, and patient whose attending physician certifies them they are unfit, or if patient is too ill. So my BCC study is a multidisciplinary study. We mainly have 6 subsections, which is which are nutrition, physical activity. We also collect data for complementary alternative medicine, financial access, and also work-related information like return to work and the psychosocial support, costing. And other than that, we also collect the biomarker and biochemical finding and sociodemographic and clinical pathological information. And the outcome of our study is to see the quality of life and the overall survival of our patients. So once the patient comes to UMMC, actually from the IPS circuit, we screen the patient. And then we see which patient are eligible, and then we try to recruit them in the surgery and oncology clinic. And then we interview them for baseline, which is within 4 months of diagnosis. And then we collect more data and also blood and tissue from that and send to biobank. We take interview also again during follow-up period during 6 month time, 1 year time, and 3 years and 5 year time point. So these are all the domains. You can see the instrument. We use different questionnaire for all our 5 subsection. Only for the nutrition part, we collect the information through food diary and using mini food album. And also we measure the anthropometric measurement in different time point. For food diary, we use during 1 year time point, 3 year and 5 year time point. And other than that, for the costing part, we actually ask patient during the 6 month period extra, and then we collect blood mainly our baseline and 1 year time point. So currently we have at baseline 990 patients who completed the questionnaire, 6 months 586, and these are the details. We have information for the patient in 1 year, 3 year, 5 year, and these are the information of the food diary we got from patient during different time point. Also biobank information. So our response rate is 65%. Actually, it was 74% during 2019. It dropped out during COVID time due to we couldn't recruit many patients for the pandemic. So today, actually, I'm going to share some of our research findings from different sections of my BCC. First, I'm going to share about our psychosocial support group. They have done one study in 2015 for the anxiety, depression, and perceived social support and quality of life in Malaysian breast cancer patient. They saw these things during 1 year time period. And they found that the hospital anxiety disorder system shows that the anxiety and depression subscale score for the subject were relatively low, and the level of anxiety reduced significantly at 6 months and 12 months. And there was no change in the level of depression over the study period. And then the Malaysian breast cancer women, next we found that the Malaysian breast cancer women had relatively better quality of life with lower level of anxiety and depression. And the perceived social support was an important factor for better quality of life, and low level of psychological distress is the reason. So then after this one year study, we want to see the anxiety, depression, and perceived social support more. So we embark on the next step, which we have done the perceived distress and its association with the depression and anxiety in breast cancer patient. And the next study actually found that patients' perceived level of distress, anxiety, and depression was significantly reduced 1 year after diagnosis. And those with perceived level of distress had significantly higher anxiety score even after adjusted for the underlying depressive score. And the most important finding was that the anxiety was more significant psychological state for our cancer patient that contribute to the feeling of distress in breast cancer as compared to depression. The next study I'm going to share with you all, that's the our patient use complementary and alternative medicine. Before we capture at the baseline what they use before diagnosis, or they already know, but that time what they are using, and also different time point. But this study done on 400 patients like who use before diagnosis. And from the study, we found that actually 35% of our breast cancer patients in UMC actually use the complementary alternative medicine prior to seeking hospital treatment. And the most popular CAM modality was dietary supplements they use. And the Malay ethnic group was the largest group of CAM user, followed by Chinese, Indian, and also the patient other than the Malay who has many comorbidities, they are more likely to use CAM. And we also found that the majority of this CAM user did not disclose the use of CAM to their doctors. They think that it's not wise to share with their doctors, and most of them use these remedies based on the recommendation by their friends and family members. The next finding I'm going to share that our nutritional group findings, they have actually done 2 studies. Our nutritional group actually collect the information through the food diary you can see here, and also using the mini food album. We give these things to our patient, and they actually take note for 3-day food diary record and send back to us. And to guide them, this mini food album is used. The first study which was we done, that was to see the nutritional status of breast cancer survivor in 1 year time point, in which we found that alarmingly 66% of our participants were actually overweight or obese, and most of them has low fiber intake and low calcium intake even after 1 year. And then among the Malay ethnic group, they consume higher saturated fat, and intake of fiber was low also more among the Malay group. So this was the 1 year, just after 1 year after the diagnosis of cancer. Then the next thing we wanted to see, like how the dietary intake in the long run of the patient. So what this study group done, they try to see the 1 year and 3 year time point. Is the dietary intake change or not? And also there is any anthropometric change or not. So among the 112 participants who participated in this study, we found that for the anthropometric result, patient body weight still significantly increased in 3 year time point, and the body mass increase also, even the body fat percentage also increased 3 year. 1 year it was already high, and then 3 year also it increased, although it's not significant. And then still our patient in 3 year time point, the fiber intake and calcium intake is below the recommendation, and fat intake is still high in above the recommendation by the Malaysian Dietary Committee. And the second, the summary of our second dietary intake study was, we found that 45% of our participants had high fat intake at 3 year post-diagnosis, and more than 90% of our participants had low intake of fiber calcium at both 1 year and 3 year post-diagnosis, and there is significant decrease were observed in the intake of energy, carbohydrate, sugar, fiber, calcium, all this in both time point. And also more than 60% of our patients are overweight and obese. The next study I'm going to share with you, our physical activity group has done one study to see the physical activity level of our patient. And for this purpose, we actually use global physical activity questionnaire, which has mainly 3 domains. That one is transport, work, and the recreational factors we measure by using the MET. MET is actually measure 1 MET equals to 1 kilocalorie per kg per hour, which is equivalent to the energy cost of sitting quietly. And alarmingly, we found that our participants who were 48% were active at baseline. The active, this one declined with time significantly in 3 year time point. And this active participant, we measured the participant if they do that their total MET is 600 MET per minute per week. And we also found that all the 3 domains actually reduced with the time point. And this blue bar showing the total working load that our survivors does also decreased significantly with time at 3 year time point. Then we want to see the factors which are affecting the physical activity among our cancer patients. And we found that in our multivariate analysis that after adjusting the age, stage, and chemotherapy, other things, the 2 important factors like time is one of the important factors which shows us that with time, people more likely to be less active. And also the hormonal therapy shows significantly that people who take hormonal therapy, they are less likely to be inactive. Then another study I'm showing to share with you, like return to work among our breast cancer survivors. This was a pilot study actually we done in 2017. We found that at that time, at our baseline, there was 579 patients, and out of them, only 40% of patients were working. And when we collect the information 1 year after that, they have returned to work or not, we found that 45.7% of our survivors returned to work during 1 year follow-up period. And when we saw...
Dr. Tanya, you only have 1 minute to conclude.
Okay, and then the mean, we found that the mean sick leave they have taken is 6.36 months. That's around 6 months. And also the constraint they face are the physical, cognitive, psychosocial changes, and motivational factors for them were salary and other things. And also when we ask, they need actually rehabilitation in return to work. They want the physical, cognitive function, work behavior rehabilitation for themselves. So there are many, as a whole, there are many strengths and weakness for our study. This is the first study. We capture so many things, and our biobank is internationally maintained. But the key thing we found that in our study is actually our patient got many unmet needs, like they have anxiety, depression, they need the perceived social support, they have financial difficulty, which I haven't shared with you due to time constraint, and they have dietary, they have always suboptimal dietary intake, they are overweight or obese, most of them, and they got many other problems. But so they have many unmet needs, which we actually need to address. And that's how we actually started in 2016, our human breast cancer survivorship program. We do once in a month. There was an interactive group discussion with dietitian, sports physician, rehab. And we used to train them. But later we found that there is some issues like referral issues, time, and the patient issues. And we don't have only the unmet need of patient, we have some unmet need for our healthcare provider. Also, there are some constraints we need to address. And that's how actually come to, we thought that we need to develop a framework for our survivorship care plan. And for that, actually, we started another study, which is not directly related to my BCC study, but that's emphasis study. Later, later presenter will tell more about this. We want to capture healthcare need and patient needs, and that's how from our evidence we can address to develop the framework for integrated breast cancer survivorship care plan in our hospital setting. These are the reference, and I want to acknowledge my BCC study team and UMMC breast cancer research team. That's all. Thank you.
Thank you, Dr. Tanya. If you look at the Q&A, there's one question you can answer in the chat itself, or we can also take questions towards the end of our session today, because we are catching up with time now.
Yeah.
We'll move on to thank you, Dr. Tanya, very, very good presentation and very informative. And I think this project is very important for breast cancer survival. And now we will continue with the second presenter. Second presentation titled Introducing the NEATBC. Original speaker was supposed to be Associate Professor Dr. Nirmala Bupati, but I think this presentation will be conducted by Madam Yek Cheng Kong, Stella, right? Is it right? Correct? Stella, are you ready? Okay.
Yeah, I am.
Yeah. So, okay, we can continue with the next presentation now.
All right, good morning, good afternoon, everyone. My name is Stella, and I'm here to present to you a tool that we've been developing over the past 2 years titled Needs Assessment Tool for Breast Cancer. All right, so I think most of you are very familiar with the stats on breast cancer. It is one of the most common cancer among women worldwide, accounting for 1 in every 4 cancer cases. In Malaysia, it is the most common cancer, and it's also accounting for 32% of all cancer cases among women in Malaysia. And in 2018 alone, there was roughly about 7,600 new cases that were being diagnosed. So when we talk about the patient journey, right, from the start to the end, this is what I guess a typical patient journey would look like when they first start having symptoms and they start seeking help, and then to getting a diagnosis of breast cancer. And then they are faced with, treatment choices on what treatment should they get, can they afford it, and whether they need to do surgery, and actually completing and adhering to those treatments, and hopefully survive, or hopefully not, disease progression. So at every knot that you see on the patient journey, patients will face needs, right? Be it financial needs, be it like anxiety, depression. So the question is, what do they need? And to actually ask what do they need, you need some kind of a way to actually scientifically collect this data. And the question, this begs the question on how do you measure needs? So actually, needs measurement questionnaire have been around for some time. As you can see, this is just a snapshot of some needs questionnaire that has been developed specifically for breast cancer patients. And you can see that, for example, the first one, Toronto Informational Needs Questionnaire for Breast Cancer, it was actually developed in 1997. So it's been developed, so needs assessment tool have been around for quite some time. Recently, it's been getting more and more as people recognize the importance of actually measuring and understanding the needs of cancer patients. There have been a lot more recent questionnaires that have been developed. However, in terms of the Malaysian context, right? This begs the question of, are these tools that have been developed elsewhere, are they relevant to the social cultural environment here in Malaysia? Like, is a tool that's developed in Canada or Turkey, for instance, would the questions that they ask, is it applicable to that of the situation in Malaysia? And also, what about, like, we're a deeply religious country with multiple ethnicity, multiple sort of cultural beliefs, and that does play an influence, in how we perceive the illness, in how patients would adhere to treatment, follow-up treatment, and maybe even survival. So again, are those tools that are developed in other countries, are they going to be relevant in our local context? And maybe also importantly, our legal and health system plays a very, very big part in how patients get help, get treatments, and even in the type of issues that they face. For instance, in our setting, we don't really have very good employment protection policies for cancer survivors, right? So how would that be taken into account in these tools that have been developed elsewhere? So given all this, we decided to embark on a study to develop and validate a needs assessment questionnaire that is specific for Malaysian women living with breast cancer. And this is just a rough flow chart of our methods. I will go into more detail in the subsequent slides, but basically our study was divided into two phases. The first phase was mainly focused on developing the tool and ensuring that we have a tool. And then the second phase involves a lot of statistics, where we wanted to make sure that our tool was a good tool, essentially. All right, so in the first phase, we essentially, it could be roughly divided up into three components. The first component involves item generation. So what that means is, what we did essentially was we scoped literature. We did a extensive literature review. We looked at all the questionnaires that have been out there. We gathered what sort of questions that were items. They use the word items for this. We gathered what sort of items were in those questionnaires, and we came up with a list of items that were in those questionnaires. But I think most importantly, at least in the context of this research, was we actually also scout previous qualitative studies that were conducted locally among women with breast cancer in Malaysia, where we actually interviewed patients about what do they need throughout their whole cancer journey. And we actually extracted information from that. And actually, we came up with initially we came up with a list of I think more than 100 items, and we realized that obviously it wasn't feasible to get patients to answer 100 items. So we then the research team then sat together and tried to simplify or combine those questions together. So we initially came up with 67 items based on just pure literature review and also analysis of our local qualitative studies. So after that, we did something called content validation, where we presented our list of 67 items to experts in the field, including breast cancer survivors, NGO representatives, And we essentially asked them, what did they think of the questions? Were the questions important? Were they relevant in regards to needs of breast cancer patients in the country? And also ask just for their opinions, like, should we add something? Should we not? Should we delete something? Should we rephrase something? Because these are people who has either been diagnosed with cancer or worked very, very closely with breast cancer patients. So essentially, there's a lot of statistics involved, but just to simplify it, we did sort of like a Delphi method where we first sent the first 67 items to all our experts and asked them for their feedback. And after obtaining their feedback, essentially, based on some statistics, we had to delete 8 items, but we added another 8 items, and also did some just based on face validity. We had to they've recommended us to rephrase 9 of the questions to make it easier for patients to understand. And they also suggested, instead of throwing out a list of 67 questions to the patients, it would be easier for the patients to read if we were to divide it into the specific domains, like categorize it into specific domains. So that was essentially what we did in this content validity round. We still ended up with 67 items, but we had divided those 67 items into 5 different domains just to enhance readability of the questions. So then we proceeded to pre-test our questionnaire in a small sample of breast cancer patients, and we actually translated. Our questionnaire was at first generated in English, so we translated it to Malay also. So now we had a dual language questionnaire, which was essentially, it has English and Malay in it, and we went and asked patients, to read through, to ask and get their feedback on what do they think of the questions? Is it easy to understand? Is the content sensitive? Is it too out there? That kind of thing. And generally, we had very good feedback. They found the questions easy to understand, and they had no problem reading it actually. However, the issue that we faced was so initially we asked them to rate for each question, asked them to give an answer whether from a scale of no need to high need. What is their level of needs for that particular item. And we realized that a lot of patients did not really like or could really grasp the concept of this no, low, moderate, and high need. And so we scraped that, and we decided to change it to a 5-point Likert scale instead, hoping that it would be easier on them to visualize also as a scale. And we found that after retesting it in the second round, that this was a lot more well accepted. People were able to easily understand this scale more. So this was the scale that we used, and essentially all 67 items passed were considered readable, and they could be easily understood. So then with the 67 items and with this scale, we proceeded to actually validate our questionnaire. So in phase 2, after developing the whole questionnaire in phase 1, it's testing the questionnaire to ensure that it is reliable and valid. It involves a lot of stats, but essentially these were the main tests that we performed actually. In terms of reliability, we tested the internal consistency of the questionnaire. We tested whether the questionnaire was stable, retest reliability. We tested the structure of the questionnaire through our exploratory factor analysis and confirmatory factor analysis, and we tested our questionnaire against another questionnaire through our criterion validity. So before we go into all that, our phase 2 was actually conducted among close to 700 participants, and this is just the distribution of the social, demographic, and clinical details. We do have a good distribution in a sense. The social demographic distribution roughly mimics, is quite close to what you'll get in our population. And in terms of the clinical distribution, we do have quite a good distribution of women who were more recently diagnosed to women who were diagnosed more than 6 years ago. And we also have a good representation of early breast cancers and advanced breast cancer patients. So in terms of the reliability, essentially the magic number we have to look at is the Cronbach alpha. And there's a lot of stats behind it, but essentially it showed that our items were good and they were reliable because we had a crumble alpha of 0.96. And also from the reliability, we realized that besides the 5 categories that we already have, we might need to also add 3 more categories, which is the diagnosis category, the sex and fertility, and a category related to healthcare services. So we kind of redistributed our 67 items into these 8 categories. And then in terms of the test retest reliability, where essentially what we did was we asked the same patient to answer the same set of questionnaire 1 week later, essentially to test whether the questionnaire is stable. And we found that it was stable. The patient's answers did not change much after 1 week, with a interclass correlation for each category ranging from 0.74 to 1. And in terms of the structure of the questionnaire, which we performed using EFA and CFA, we found that the domains itself were very good. We had very good conversion validity, and they were also significantly different from each other, each domain, like the diagnosis and sex and fertility were quite different from each other. So we had very good divergent validity. And in terms of testing it with another questionnaire, right? So the questionnaire that we chose was the EORTC QOL questionnaire, which I think is a very very widely used tool to test for quality of life in cancer patients. So based on our literature review, we know that patients who have reported higher needs tend to have lower quality of life. So that was what we tested for our questionnaire. We calculated an overall score for needs, and we correlated it with the global health status from the EORTC questionnaire. And we did find a negative correlation of a 0.29, which was significant. It was not big in magnitude per se, and that was because so for our needs questionnaire, we have a lot of domains, right? We ask things related to diagnosis, we ask things related to financial, to employment. So the rationale is that because our questionnaire involves a lot more than quality of life, such that for example, if you're already a long-term survivor, you probably rate diagnosis needs very low, so you might not have that. So that's what contributes to the low magnitude, but it was significant. And tada! After all that hard work, we came up. We had a validated tool that is specifically developed and validated within our local context. It is available in both English and Malay, so that it will be easier, especially so that it's very easy to administer in our local population. And the final questionnaire consisted of 8 main domains, comprising 50 items. So yeah, I forgot to explain that in the CFA and EFA, we essentially had to drop some items because of some, it showed that it wasn't a good fit for our questionnaire. So from 67 items, we were left with 50 items overall, and it was distributed across 8 main domains, which was diagnosis needs, questions regarding information needs, psychosocial needs, self-care and personal health, healthcare services, sex and fertility, financial needs, and also employment needs.
Stella,
yeah,
just need to remind you that you need to wrap up in 1 or 2 minutes.
Okay, I'm actually done. So these are my references. Thank you.
Okay. Oh, you're done.
Yes, yeah, that was my last slide.
Because we have to keep in mind that there's another event at 1, so we have to really make sure that we follow the time given.
Yeah.
Without further ado, we can very interesting, yeah, very interesting work by Stella and team. I think you can take this to a very to the next level, yeah? And I'm sure there will be a lot of interest when you actually finish your project. This is very crucial for the breast cancer community. So congrats, Stella. And now we move on to the next presentation, which is the next presentation by Associate Professor Julia Patrick Inkason, title Healthcare Provider Gaps in Survivorship Care. Julia, you have
sure.
about 15 minutes.
Yeah, sure. Yep.
All right.
Okay.
Thank you.
Thank you, Sarina. Right. So I'm Julia. I think, yeah, Julia. So I'm from Department of Rehab Medicine, and I'm involved with this IIRG sub-program project titled Exploration of Needs of Patient and Health System in Implementing a Cancer Survivorship Care Plan. And this is the IIRG reference number. So what I'm going to do now in the lecture is going to tell you about what are the healthcare provider gaps in survivorship care. And yep, so as you all know, survivorship care is part of supportive care for breast cancer, and it is a distinct aspect of cancer treatment that should be integrated into breast cancer care problem. And there is a need to develop and implement a breast cancer survivorship care plan in Malaysia based on the available healthcare resources and service. So with that, this is the rename of our project, the same thing, but we like to have some acronym. So it's Exploration of Needs of Patient Health System in Implementing a Breast Cancer Survivorship Care Plan, SCP in Malaysia, we call it emphasis. So the ultimate aim of this project is to develop a framework for integrated breast cancer survivorship care plan in the Public Healthcare Institute in Malaysia. And this study consists of 3 phases. But what I'm going to share with you is the result that we obtained from phase 1. Now we are at the end of phase 1, coming to phase 2. Yeah, so phase 1 is to develop a health system need assessment questionnaire, just similar to what Stella had presented earlier, right? But now is to assess health system need assessment, right? So the first thing that we need to do is to see what is happening now. What do we have now with regards to breast cancer survivorship care plan? So it was meant to be a workshop with focus group discussion. It was planned in March 2020, but because of COVID, we have to turn it to a online survey. So we made questionnaire. The first round of questionnaire was developed by panel subject experts, the survivorship researcher, clinician in breast surgery rehab department. And we had the questionnaire being validated, content validity and face-to-face validity was done by 2 rated healthcare providers. Basically what we asked is that what are the various felicitators and need of healthcare providers in these 5 different domains, which are psychosocial, lifestyle modification, financial, cancer rehab, and genetic counseling. So basically this is what we have. We have questionnaire, and we have, these are all the 9 questionnaire, right? So I'm not going to read one by one, but for this study result that I'm going to present is mainly from Q2, Q3, Q4, and Q5, asking them what do they have. And each of these psychosocial, lifestyle, financial, cancer rehab, and genetic counseling domain have different participants. Not all participants answer all domains. So we have participant in psychosocial, participant in lifestyle, and they answer all the 9 questions. And this is an open-ended question. So it is freestyle answer. So what we invited 107 participants and 55 respondents, that's around 50%. So the range of participants is varied. We have cancer survivors, we have NGOs, and we have a wide range of healthcare professionals from dietitian to primary care physician, rehab, surgeon, oncologist, nurse, medical social worker, and physiotherapists, so a range of them, right? And they are identified through snowballing, because we know that the breast cancer survivorship care plan is not existing. So we ask around who would be able to give a good feedback. So I'm going to share with you the themes that we gathered just to illustrate what are the gaps in healthcare providers. So I'm going to go through the themes, Right, so the cancership journey, everybody said, a lot of participants said how important it is and how important is it to have it clear right from the start. For example, a surgeon, said, patient navigation from time of first clinic visit until initial treatment and completion of treatment is extremely important to allay fears and align expectation. right? And this is an NGO administrator. We said that cancer is a big word, right? So it's important to navigate the patient and family members through the cancer journey. And a rehab physician mentioned that patient navigation during acute phase is important to ensure that patient is not lost within the system, because we know that cancer treatment have a lot of different discipline involved. So it's important to have the journey clear right from the start. And this is a surgeon, right? So patients should be given a very clear-cut plan on how surveillance will be carried out and what to watch out for alarming signs, because one of the survivorship aim is to make sure that patient know about recurrence, right? And she explained about the two spectrum where patient, one spectrum is when no one, where the patient is ignorant and feel happy, right? The other one is of constant fear. So there is a need to make sure that patient knows what is in plan for them, even though after the treatment is complete. And this is from a cancer survivor. This is quite a good suggestion. So there should be a communication, yes, what is expected for their active care. So she suggested there should be a checklist, a booklet, similar like antenatal booklet at Klinik Kesihatan. The emphasis are not well done by healthcare professional on the follow-up, right? And what are the actions to be done if they face any suspicious or abnormal finding again? And another cancer survivor said, most officers do not have resources for survivors in this period. This period refers to the long-term period, the permanent period that is after 1 year, right? Survivor, we meet with the patient or surgeon once a year for 10 or 15-minute session only. So obviously, the journey, the cancership journey is not clear for the patient, and this is acknowledged by both the patient as well as the doctors. Return to work program, I think Tanya mentioned this in her lecture just now. So this is a cancer survivor telling that survivor need to be given work modification, and employers need to know what to expect. And some survivors experience prolonged fatigue and can't cope with work demand as before. So they might quit their job or reduce productivity. So it is important that return to work is important for cancer survivor, even though on physically they do not have disability, because what they have problem is something that we can't see. And this is naturally from rehab physician, because we deal a lot with return to work program, maybe not for breast cancer patient, because we don't get referral much, but it's for in general, right? So adequate staff and equipment for occupational therapists to conduct detailed return to work assessment, and more NGOs that can offer job search and job opportunities to patients with disabilities. And public policy should be developed and implemented to support cancer patients from diagnosis to return to work. And they also say that there is a need to acknowledge with other people, because return to work, you need to work with the employers as well as with so. And just to let you all know, return to work program is not widely available even for other people with other disability, right? Only a few rehab services have this. And cancer rehab, and then the next we go to the gaps in cancer rehab service, right? So a physiotherapist who mentioned that early exposure to cancer rehab at least a week before cancer treatment or operation, right? It should be exposed to them. And then cancer rehab for post-operation should start from post-op day 1 and continue at least until they finish their cancer treatment. And long-term monitoring is very important for survivors, especially to detect early lymphedema, so that they can treat as soon as possible and maximize their quality of care. And the rehab physician emphasize the multidisciplinary cancer clinic should be there to provide a one-stop treatment for cancers, for specific cancer patient, because if you remember earlier, the same rehab physician mentioned about the patient getting lost in the system if the journey is unclear. And this is the gap now, right? So current rehab program in this institution only caters for those with disability. And it's not only this institution, but in most institutions, we cater mainly for those with disability. So there is a need to develop a recognition program for those without disability. And for example, it is cancer for people with cancer. And it is not very surprising for a physiotherapist to say that cancer rehab is not a well-known service among healthcare providers hospital, because cancer rehab does not exist in a lot of rehab medicine services, right? Especially outside Klang Valley, right? Patients outside Klang Valley usually unable to receive proper rehab treatment, and they can't come to this hospital because of logistic problem. And yes, she mentioned it, hard to refer them to the nearest hospital. There is lack of cancer rehab therapists, which is true. So there's not enough manpower to man the cancer rehab services. Right, but then it is not something impossible. This rehab physicians like cancer rehab program can simulate existing cardiac rehab program, but needs staffing and training and a very close relationship between primary team and rehab team, because we normally rehab need feeders, right? And patient also need to buy in, as it will require regular attendance. Now, one thing that one domain is lifestyle, and in lifestyle, what we ask mainly is about healthy diet and physical activity, right? Which we have input from dietitian here, right? So it is crucial, as normally patient receiving inconsistent information, and sometimes not at all manage to get consultation with the allied health professional due to inadequate staff. And because of that, they got different resources and patients are confused. Some patient continues the same dietary regime from acute until they are discharged. And the second one is a very interesting feedback. Most work, which is with regards to active lifestyle, are done ad hoc and not planned in advance. It becomes apparent when breast cancer month is around the corner, and then it goes quiet for another year. So that they illustrate the gap of having a regular or consistent activities for the patient. Right, and this is from an NGO administrator. So what I want to highlight here is that we always assume people know what active, healthy lifestyle is. But what he said here is that diet is always on discussion, as it is complex to define, and to define what is healthy for them, right? So therefore, they need assistance to manage their dietary. And we also get some feedback on, because one of the questions we ask is about role of primary care medicine specialists. And this is by a surgeon, surprisingly. The primary healthcare already have many other existing programs for various pathologies, which is true. One of such should be focused on cancer survival. It can be grouped under women's health. And the tertiary centers and primary healthcare centers should have a networking system to be able to channel or list cancer survivors within the vicinity. So this illustrates the role of primary care medicine specialists in healthy lifestyle. So there is another one that is from a primary care specialist herself. We say that this is where primary care physician can start to influence lifestyle management since the beginning. They might not be the one who manage the cancer, but they should be at least to advise the correct next step if any such cases of cancer, where to get support, who will be referring, and what is the next step. So this is very true, because if you listen to Prof. Aisha earlier, right, the role of GPs in helping in survivorship care, where they can actually detect and then should know the system so that they can tell the patient where to go. Right. This is something that comes quite strongly from the patient, actually. Doctors, especially surgeons and oncologists, should be more humane towards their patient. And excuse me, I maintain this in Malay, yeah. Dari segi perubatan, saya rasa perubatan di hospital ada baik. Cuba, saya rasa doktor perlu ada sikap empathy terhadap pesakit. Doktor seharusnya memberi kata-kata semangat kepada pesakit kanser. And an academician from UKM said, many patients with cancer experience anxiety towards fear of progression and recurrence during extended survivorship. This is seldom addressed. So there is this psychosocial needs that is not met. And this is feedback from cancer survivor in bold, just concentrate in bold. So they might have announced hundreds of cancer diagnoses, but for the patient, that was the first time, right? So this illustrates also the lack of emotional support that they expected from the doctor. And this is when, if caregivers are not educated about this, they will look for other means, example, traditional medicine or bomoh to cure cancer. In education and training, I think all the domains that they need training, they need more number, they need specific training just for cancer. But something that caught my eyes is that what the breast cancer survivors said. Doctors must be trained to break the news to patient. So a lot of these things, if we don't get it, if we don't do this, we are unable to know what actually is needed for a good survivorship care plan. And space. Of course, there are more quotes on space telling that they need space for therapy, they need space for consultation. But I'm just showing you that the space for patient means different thing, right? So what the patient and also even the surgeon, right? A designated space is important to provide patient a sense of privacy, right? Because we're talking about breast cancer. A grief room needs to be allocated in the clinic itself, where patients who have just informed about the diagnosis can spend some time to cool down before heading home. Financial needs, of course, we all know cancer care, surgery, chemo, long-term chemotherapy, radiotherapy, they all have financial needs. And an interesting quote from the surgeon, while we are aware that there may be financial implication, our work process never explore financial issue of the patient. From the cancer survivor, follow-up medication still require money. Changing to a healthier diet means higher food expenses, right? We promote healthy diet, we promote exercise, but it all comes with money. And from the rehab physician point of view, lack of funding for consumable like compression garments, thermoplastic cleans material to cater for this patient, because these things are something that patient have to buy. Compression garments for lymphedema, just for information all the audience. Right, so in discussion, right? So the study described gaps in survivorship care from the perspective of cancer survivors, healthcare providers, NGO, and I believe that it gives us a more better understanding of what is lacking, and there is obvious need to improve cancer survivorship care in Malaysia. We can see that from the quotes. What are the things that need to improve? There are various model of cancer survivorship program available, because cancer survivorship program is not new, right? Especially in the developed country. The real challenge is how to develop it, to develop a framework for cancer survivorship care plan that is appropriate for our local context. That is the main aim of this study, is what are the things that need to be adapted, modified, changed to suit our local context. And that actually is the end of my presentation. And after after reading all reading the result, and it is very clear that the cancer journey is very far, and it is very important to have a clear expectation, and very important to see that there's a rainbow at the end, because fear is something that is mentioned quite a lot of time in the survey. Clear pathway, right? The clear expectation, and we ourselves, I think, need to be clear as well. With that, I would like to thank you all who have contributed to the success of this survey. Thank you.
Thank you, Professor Julia. Did very interesting. Yeah, some of the points raised is quite important and interesting. Now we move on to the next presenter, Dr. Temizi and Dr. Kavinya. The next topic is early recovery after surgery, ERAS. So without further ado, we will call upon Dr. Temizi to start the presentation.
Thank you, Prof. Sarinder. Can you see my slide?
Yes, yes, I can see.
I will just enlarge it.
You can put a presentation mode, yeah?
Yeah.
Yeah, present.
All right, is that okay?
Yeah, yeah, good.
Yeah, so my topic today will be on ERAS in breast cancer surgery. This is also part of the survivorship program for breast cancer under the big umbrella. So the topic is improving quality of life of breast cancer patients in the immediate post-operative period using the Enhanced Recovery After Surgery, ERAS protocol. This project is also part of a sub-program of the breast cancer survivorship plan and under the IIRG grant. This part of the study was allocated almost around RM 60,000. I am the sub-program leader, and my co-investigators are Prof. Aisha, Dr. Kavinia, Dr. Lim Woon Lai from anesthesia, and Dr. Tanya. Cannot move. Somehow cannot move the slide.
Now it's moving.
Now, okay, yeah. So ERAS, or Enhanced Recovery After Surgery, is a multidisciplinary and multimodal perioperative protocol to improve immediate surgical outcomes. Regional anesthesia plays a big part in ERAS. So our aim is to improve pain relief, to reduce opioid requirements and opioid-related adverse effects, and hopefully with this, we could reduce length of hospital stay. So our program objective is to compare, the primary objective is to compare perioperative opioid consumptions for patients undergoing mastectomy with and without regional anesthesia. And the secondary objective is to compare pain score post-op nausea vomiting, we call it PONV, and also the length of hospital stay. This is the methodology. These are all the things that we had to go through, and just to highlight some of the things that we have gone through for the IIRG grant. So the venue of the study is UMMC, and study duration lasted from January 2017 until March 2020. And the study population includes all patients who have undergone unilateral mastectomy within that period of time. We have attained ethics approval from the MREC, and our grant is IIRG grant. These are the timelines of the program. So we conceptualized the idea in 2019 November, and because of the pandemic, if you could see this column, there is original timeline and also updated. The updated timeline is because we had to extend the study due to delay in data collection because of the COVID-19 pandemic. So we managed to extend the IRG grant for another 6 months, and at the moment we are at this stage. We are at write-up and publication. So the study has concluded. So for interdisciplinary interactions, we have several meetings throughout the duration of the study. We have internal meeting of researchers, meeting with various disciplines to discuss study protocol. And we also had meeting to review data collected, data analysis, review and amendments, finalizing our data, discussion on outcomes, and at the moment we are at the stage of write-up. So as part of the IRG, we have to talk about impact. So impact statement, we aim to assess a protocol, which is the ERAS protocol, that will improve the quality of recovery in patients undergoing breast surgery. This may pave the way from traditional recovery after surgery to enhanced recovery after surgery for breast cancer patients. So these are our impact pathway that we had to present during the IIRG progress review. So the impact summary in this column is the question asked would be who will benefit your research? So all patients with breast cancer needing surgery will benefit. And what will be the benefits to them from your research? The benefit is to improve quality of recovery during the immediate post-op period. And hopefully with that, we managed to get cost saving due to reduction in length of hospital stay. The other column will be this may be helpful for structuring your impact with summary and pathway. How would you categorize this benefit? Is it beneficial to the public and also the healthcare industry? And how we share our research with the team. We went through a pre-operative patient navigation with our breast cancer nurses and patients, and also a multidisciplinary team education amongst the surgeons, the anesthesia team, and also ward nurses. When are these activities going to take place? These are the duration. Actually, it's 2017 to 2021. And all investigators will be in charge of navigating all these protocols and through multidisciplinary team engagement. So we aim to look at improved post-operation outcome and also patient satisfaction. So some of the constraints or problem we encountered during our study is, of course, the glaring COVID-19 pandemic. And this pandemic has caused a major shift and delay in our elective operation schedule. Therefore, it has caused also delay in data collection. However, these are unavoidable, and the IIRG grant committee allowed a 6 months extension of our study. So in terms of research outcome, we managed to collect a total of 335 patients during that period. And we are actually analyzing those prior to the ERAS group and during the ERAS study, which looking into regional anesthesia. So from this, we can conclude that opioid consumption is lower in the PAX group. Our regional anesthesia used for breast mastectomy, breast surgery, is PAX2 block. We block the pectoralis nerve, serratus, long thoracic nerve, and also intercostal nerve. This is done by the anesthesia pre-operatively just before induction. So through this study, we can see that it's actually about 3 milligram lower. And the length of hospital stay was also shortened by 1 day in the regional anesthesia group. Pain score and post-op nausea vomiting were, however, similar between both groups. So through this study, we could actually conclude the findings of this study suggest minimal effect of regional anesthesia on total perioperative opioid consumption. The opioid consumption was only around 3 milligram lower. However, it is statistically significant in the groups of patients that receive regional anesthesia. This 3 milligram lower may not be clinically significant, although it's statistically significant. We also find out that overall low opioid dosages amongst our patients may be attributed to the usage of multimodal analgesia. Some of our patients receive IV paracetamol, IV parecoxib, and also even gabapentin pre-operatively. And then many of our Asian populations are opioid naive, and the Asian population overall has a higher threshold for pain. And the length of hospital stay was also 1 day shorter, and this is a significant value in patients that receive regional anesthesia. The reason why is because they have improved mobility after surgery, hence because social, logistic, and economics factors play a role. And discharge within 24 hours after surgery allows consideration for day of surgery admission or 23-hour admission. So if the patients were admitted as a day case without needing inpatient admission, so there will be cost benefits. There is no significant difference in pain score and post-op nausea and vomiting, however. So this is our lay abstract from the study. So we can conclude that this protocol may improve the quality of recovery in patients undergoing breast surgery. And this may also pave the way from traditional recovery after surgery to enhanced recovery after surgery in breast cancer undergoing total mastectomy. This is a part of our ERAS protocol. I'm sorry, it's a bit small. So we basically separate it into pre-operative assessment with a patient navigation, patient information sheet, pre-operative anesthetic assessment as well. And then pre-operative patient fasting protocol and medication include antimicrobial prophylaxis. Intraoperatively, as was discussed earlier, regional anesthesia and normotomia, euvolemia, and post-operatively optimization of oral medication. That's all from my study. Thank you for your attention.
Thank you, Dr. Temizi. Did a very compact presentation, and yeah, we'll take up some questions if there's questions later on, maybe after all the presentations. So the next presenter is Dr. Liu Win Shen and Dr. Teo Li Ying. The topic is implementation of financial counseling in UMMC. So financial counseling is a very crucial aspect, yeah, of in UMMC of the patients has to really bear a lot of cost sometimes, and they don't have the means to fork out the cost of their treatment. So this is some we'll hear from the experts, Dr. Liu and Dr. Teo. Without further ado, I would like to invite Dr. Liu for the presentation. Thank you.
Hi, Prof. Sarinder. I think
Yes.
Dr. Liu is not yet ready, so maybe we can entertain for Q&A first while he's logging in and setting up.
All right, sure, no problem. Thank you so much for the heads up. And there is a question in the chat box for Dr. Tanya. Dr. Tanya, the first question. Wait, let me look at the questions. Okay, the question is for Prof. Julia. The first question.
Right,
Prof.
okay.
Julia.
Oh, May I? I mean the
Yes.
first one about this cancer rehab patient, right? So normally by having modified less cancer. All right, so that is so we do return to work program, and as I mentioned, a lot of our patients have some form of disability. So there is when we have the return to work program, one of the first thing is we inquire about what work they do, and then actually we have a few meetings with the employer. It is a must, right? And then we need to reach an agreement. What is their job scope? What's the requirement? And then we will have a detailed assessment on what they can and they cannot do. And this is after a few series, because normally when we have patient with, let's say, for example, disability, we start it early, so we know what they can and they cannot do. And it really depends a lot with the employer actually. Some employer are very accommodative. Some employer just said, I paid for this much, you're supposed to do this much, and with that I say, why not you just stop working for me? There is such thing, and then these are the things that we cannot stop. But we hope that with more and more awareness. And I think the pension survivorship of the breast cancer patient, they can work compared to those who might have a bit more severe disability. And it is a lot of discussion and give and take. And whether it's fair or not for the co-workers, we have to address the whole environment. There is no real answer to that. Sometimes it is really difficult, yeah. But we have to try. And the more awareness the employer and the people have, the easier the path for them to go back to work. Thank you.
Thank you, Prof. Julia. We move on to the next question since we still have some time. For Dr. Tanya.
Actually, for the physical activity one, they ask like for physical activity it's done during pandemic term or not, but our study actually end before pandemic. In 2019, until 2019, we took the sample. So it was not during pandemic time, and actually our physical activity level reduced in time. There is nothing relation or no relation with the pandemic period. And previously there was another question, I don't know, I actually answered that one. The participant asked like our anxiety, depression, have we seen the income level with any relation with the anxiety and depression? But for our first two study I share, we haven't checked the anxiety with income level, but in future we are planning to see that one.
Okay, thank you, Dr. Tanya. You had two questions. So one you answered live, and the other one, I mean, both you attempted to answer here, which is very, very good. So the next question by Anil. Hi.
For me, right?
Again?
It's probably for me, I think. Yeah. May I ask?
Yeah.
Yeah. All right.
Yeah.
Yes, we do. Yes, we did. And there are at least, so we have both the cancer survivors as well the NGOs. Like when you say NGO, those are the related association. What I value most is something that we for that things like the emotional, things like what is healthy diet, you know, those are the things that we take for granted. If you ask the doctors, I mean, you can never get that from the doctor. You can never get that, oh, I don't know how to support my patient emotionally. We assume that we can do, I think. So for me, that is the most valuable thing, the one that is unseen. We all know, oh, we don't have enough equipment, we don't have enough manpower, they all will know. But the survivorship and the cancer survivor and the NGO words are very, very strong indeed. I think it's stronger than our voice. We say that, you know, try to be humane, learn how to break bad news to the patient. Like what is healthy diet? For me, those are the things that are very important, because those are the things that matters to them. Because this is something that you want to do to improve their life, right? And those are the things that matter most, because you might have 10 CT scans, it might not improve their life if you don't break the news properly. So that are my most valuable feedback from them. Thank you.
Okay, Anil, do you have any more questions for Prof. Julia? Are you happy with the answer given, or you want to ask anything else? Because we don't have any more questions here. We look at the answered questions. Maybe we can also talk about the questions that has been answered live. If Dr. Liu is not around, or maybe she can't set up the screen.
Hi, Prof.
Hi,
Prof.
Okay.
I'm in already. Sorry for the delay.
You're in. All right, that's good.
Yeah.
Okay, can we start now, Dr. Liu?
Oh, just 1 minute, Prof.
Yeah.
Can everybody see my screen?
Yes.
Yeah, hi.
You put on present
Okay.
readability.
Hi. Okay.
All right.
Hi. Good afternoon, everyone. I'm Vincent. I'm a third-year surgical trainee in UMMC. I'm very grateful for this opportunity given to me to talk about my research. My research topic is about development of a financial counseling service in UMMC breast cancer treatment. Together with me are my supervisors, Prof. Aisha, Dr. Tanya, and last but not least, Dr. Teo. Dr. Teo would like to extend her apologies for not being able to join this event today, as she's involved in the surgical master final exam today. So before I proceed any further, I would like to express my gratitude to the following people. for helping in developing and also implementing my project as part of the breast cancer survivorship care plans. The people are the UMMC management, my unit, breast surgery unit, oncology department, Ms. Ranjit, the president of our Breast Cancer Welfare Association, and also my financial counselors, Injit Taufik and so Puan Ann. So a bit of introduction. After patients were diagnosed with breast cancer, the common two worries that go through their mind are actually the disease itself, as well as the cost of the treatment. But the real situation that was happening previously was that there's not a single personnel or department has the idea of the estimation of total cost involved in the treatment of the disease. Ended up, patients have to walk through different departments to acquire bits and pieces of information. And at the end, they still have no idea of the estimated cost involved. Thus, we feel that it is important for us to set up a one-stop financial counseling service concept. The main objective of this project is to develop a financial counseling framework for breast cancer treatment in UMMC. Then secondary objective is to determine the treatment adherence among newly diagnosed breast cancer patients after implementation of such service. So this is an ongoing research currently, and then was already approved by our UMREC. Quality improvement framework strategies are followed for the implementation of this project. So regarding this quality improvement framework strategies, it consists of 4 phases and 14 steps. So for phase 1, initiation of a whole setting, we started off analyzing our cohort from 2012 to 2015 regarding the treatment adherence rate and also factors associated with non-adherence among breast cancer patients in UMMC. From the analysis, we found that failure of financial reimbursement is one of the main factors associated with treatment non-adherence, especially to radiotherapy. In order to tackle that, our unit identified offering financial counseling might be the way to go. There's a readiness of the hospital management as well as our unit in introducing this financial counseling into their existing services. Subsequently, we started off engaging critical stakeholders, which is consisting of clinicians, list of clinicians and also non-clinicians into our project to develop this project. So for phase 2, creating implementation structure, the critical stakeholders that I mentioned just now help to develop financial counseling approaches, steps, and the counseling templates. Subsequently, we also identified and trained key persons, which is our breast cancer care nurses, oncology trained nurses, and some of our potential admin staff to train them to offer this financial counseling to our patients. Then we started off advertising this new financial counseling service to our clinicians, and we started off implementing our financial counseling in breast surgery March this year. Ongoing structured monthly meetings were organized between researchers, financial counselors, and also the clinicians to discuss problems encountered during the implementation process. Adjustment, fine-tuning, and improvement will be done after each meetings. Quarterly meetings also were being held with the critical stakeholders to update them regarding the progress of the research project. So for phase 4 in future, improving future applications, analysis of the treatment adherence post-implementation will be done at the end of the research. And critical stakeholders will help in maintaining sustainability of the project in future. If this project provides a positive result at the end, UMMC Management Board will consider expanding this financial counseling framework to other cancers and other chronic diseases treatment. So a bit more counseling process is actually a standardized 5 steps process. So what happened is a newly diagnosed breast cancer patient, after consultation with the clinician, they will be sent into the financial counselor room. In the financial counseling room, the financial counselor will go through the standardized 5 steps mentioned here. First, they will talk to the patient regarding the estimated total cost of the treatment for the patient. And then second, they will go through the patient's socioeconomic status. Thirdly, they will screen the patient for financial toxicity and also their distress level at that point of time. And then followed by, they will educate patient accordingly regarding the financial aids applications which are applicable to them, insurance and JPA claims processes, and also they will also talk about this some of the oncological drugs patient access program enrollment. Last but not least, they will navigate them accordingly. Okay, so this is some of the picture of our early development milestone for this project. So we started all this back from September last year by first presenting our idea to UMMC Management Board meeting. So once it's approved, on November, we started recruiting critical stakeholders from different departments of clinicians and non-clinicians. Then training workshops for key persons were done February and March this year, as shown in the picture. We started implementing our project in the clinic, started April this year. So along the way, there are some challenges we encountered during the early phases of implementation. Some of it are like first, difficulty translating these complex diagnostic and treatment charges into a simple, understandable, user-friendly tool for non-clinical staff and also for patients to understand. So fine-tuning were done actually quite multiple times during initial phase of the implementation. So second, COVID pandemic and the SOPs also was a challenges for us during our implementation, as meetings and training workshops have to be done virtually, and also for physical sessions, we have to limit the number of participants involved. Thirdly, the third challenge that we encountered was introducing a new financial counseling concept into the existing service, as we need to make sure that this new service actually helps the clinician and patient instead of increasing their burden. So fine-tuning was done along the way at the initial phase. So the next few slides, I will show you some of the forms and the counseling templates that we're using currently, which already we all improvise along the way. Now we are using it for quite some time now. So the first form, it's a clinician ordering form where the clinicians have to take their treatment plans while seeing the patients. So at the end of the consultation session, patients will bring this form to the financial counseling room as mentioned, and then financial counselor will calculate the rough estimation of the total cost involved according to this form. Same happens to the oncology clinic as well. The oncologists have to fill out the same thing as well. So just now we mentioned the second step about going through with the patient, the socioeconomic informations. These are some of the socioeconomic information that we will inquire the patient. Then next, regarding screening of financial toxicity, we are using a locally validated cost facet questionnaire. Patients who are found to have financial toxicity using this questionnaire will be straight away referred to medical social unit. Regarding the distress level screening, we are using this stress thermometer. Patients who are found to have high stress level will offer to refer them to the psychologist. We also formulate a list of financial aid application processes that was used by the financial counselor to educate patients accordingly, how's all the financial aids application processes and how long the duration will take them. So with this, I end my presentation. Thank you.
Thank you, Dr. Very compact. I'm glad to see that the amount of work involved in looking for patients which having difficulty in the treatments, the cost of forking out the cost for the treatment and so on. So I think this is a very good approach to identify such patients in the hospital. Now, without further ado, because we only have half an hour more, we would like to, I would like to invite Prof. Aisha. Prof. Aisha, are you here?
Yeah, I'm here.
Yeah, okay. So today this
I have to share my
presentation.
Yeah.
Final presentation, which is on journey, journeying with patient interactively in UMMC. So we'll hear from Prof. Aisha. I think Prof. Aisha mentioned this in the earlier session as well, but now she's going to present this journey project in detail. I think we have about 15 minutes for Prof. Aisha to talk about journey. After that, we will start with our discussion, Q&A, and hopefully we'll have some time for that. Thank you, Prof. Aisha.
Thank you very much. I'm going to start my presentation. Please confirm that you can see it.
Yes, we can see it.
Okay. All right. So what is journey? Journey is journeying with patients, understanding and responding to needs interactively. So essentially, it's a cancer patient journey navigation app and a healthcare provider dashboard for UMMC. So a little bit of background, and then we just go through the progress of this project. This project is also funded by the interdisciplinary research grant, cycle 2, for which I think Prof. Sarinder, you are the PI. Okay, so what is the diagram of the cancer patient journey? So the journey is actually very complicated. I think if you listen very closely to what Prof. Julia and what Dr. Vincent mentioned about what the patients face, the challenges that they face throughout the journey, you will understand that it is very difficult for them to actually experience cancer, the treatments, in a very hostile environment. Okay, so why is it really important? Because, you know, there are timeliness priorities that we need to make sure to ensure that the patient gets the best outcome. So of course, timely diagnosis is one of them. Timely surgery, systemic therapies, and radiotherapy is also very important, has shown to improve survival if you make sure your patients get timely treatments. And of course, if they recur, we must ensure that they get diagnosed and staged quickly. So just to share with you, there have been already timeliness benchmarking globally, which was launched in February this year, which expect us to resolve diagnosis within 6 days after they present with a symptom of breast cancer. And they are trying to achieve 80% adherence to treatments. So the Ministry of Health has also published this in 2018, which is their operational policy, that expects that all patients will receive their surgery within 4 weeks of diagnosis. So that's more than 75% of patients needing to have their primary surgery within 4 weeks of diagnosis. And the second one is those who have suspicious lumps will be seen in the breast clinic within 14 days. It means they expect more than 80% of them to achieve this. So how about UMMC? We do have an EMR, and our co-supervised student, me and Sarinder, many years ago, her name is Dr. Nurul, she's now in Monash. So we could actually do an audit based on the data from the EMR. But you can see that within 14 days, we are not really able to achieve the 80%. And this is most likely because we will see patients that require image-guided biopsies. So you can see the struggle to actually ensure that we can diagnose within 2 weeks. We are short of maybe about 10% of the patients, yeah? Okay, so what is really Journey? So Journey is a patient navigation app that interacts with the EMR to audit and show their journey throughout the process of diagnosis and treatments. And we are hoping that this journey is also reflected on the EMR dashboard to show the progress of the patient. This is not really anything new. It has been done in other hospitals. And what we need to do now is how we should implement this into our hospital setting. We also expect our doctors and nurses to be able to help track patients with this method, because really our breast clinic, I have to say, we have a fantastic breast clinic. We have very dedicated doctors and nurses, and we all try to make sure patients get their timely treatments, but it is a struggle. And it is something like you can reduce the quality of life of healthcare providers having to chase around each other to get appointments. So what is the objective? So that is to improve patient and healthcare provider experience and fulfill patient navigational needs in cancer diagnosis and treatment pathways in UMMC. The specific objectives is also to explore the patient navigational needs in their diagnosis, workup, and treatment pathways. We want to develop a cancer treatment algorithm to incorporate the diagnostic options, the timeliness, and all the information that we need in the hospital. And we will develop and pilot test the navigation app for healthcare providers and for to help patients, and also this healthcare provider solution to navigate our patients. And in a way, this system will produce a flagging system for the hospital to ensure that we get our patients safely with a timely diagnosis and treatments. So it is an implementation science research. So whenever we want to address a problem, there is this, it's a bit different from hypothesis testing research. We use this term called theory of change. It helps you sort of focus on what are the issues, the outcomes that you're trying to achieve, and what are the processes that you need to do to improve that outcome. So by improving scheduling of clinical visits and investigation and communication with patients, we can improve the timeliness of diagnosis and treatments as well for the patient and improve the healthcare provider experience in UMMC. So I again show this slide for those who are interested in quality improvement projects. This can actually be published. I think for most academics, especially when you are in you're always focused on publishing. So you can actually publish this type of work. And so like Vincent and many of the other students, like we had one on surgical site infection reduction, also using the QIF. And I think how many more projects? The journey is actually using the QIF project. So remember what Dr. Vincent said, the first thing you need to do is to ensure that you have engaged the right key stakeholders. And in our case, we have to ensure that we are aligned to UMMC, and therefore the key stakeholder here is UMMC. So we have gone through a process of engaging with the management, with the medical advisory committee to ensure that we are able to produce this work effectively. So you can see that we have gone through multiple things, and so how we started was really to make the base. The base for UMMC is to have a UMMC cancer registry. And so now we have a hospital registry core committee made up by myself and Professor Pang, and we have permanent representatives from all the departments in the important and relevant departments, and we have permanent representatives who are externally appointed for our researchers in the University of Malaya, and also we are involved with people from Institute IKN and the National Cancer Registry, as well as the Health Informatics Center, to ensure that when we have a registry, this registry can be sent on the back end to Ministry of Health without having to do any more processes. So to be able to do a registry in UMMC, we have to engage all our major user stakeholders. So you can see we have something like 20 units that manage cancer. And you can see that we have digitalized the cancer registry forms, and there are processes that we've put in the back end to ensure that our coding is up to the IKN as well as the International Agency of Cancer that is based in Geneva, for ensuring that all the back end reporting is coded automatically. So the surgeon and the oncologist don't have to look up for which codes. We just need to put in the diagnosis that we are familiar with, and that will be coded on the back end. So that is the workflow of the reporting, and we try to also build in the monitoring tools. So this work is currently underway. Our PTM is currently doing the programming of the requirement specification that we have worked very hard on early part of this year. So we are hoping to hear from them by end of this year so that we can start piloting in our clinics, all 20 units of us. Yeah. So now we go and focus back to the Journey Working Committee. So the Journey Working Committee actually sits under the Cancer Registry Committee, also led by myself and Professor Pang. But here we have a whole different group of committee members. We have people from radiology, Prof. Raja Rizal, or we call him Ray, and Dr. Caroline from the breast radiology team. We also have people from primary care, because we know that when people come into our hospital with a breast lump or suspicion of a breast lump, they can be seen in primary care too. We have Dr. Tay, who you met just now, who is a medical lecturer in our department and a breast surgery fellow, who will be sitting for her viva soon. So she will also be a breast surgeon soon. She and Dr. Nisha from oncology are the clinical experts that help to put together the clinical pathway that we are already doing, but more in a format that our programmers will be able to do the programming for EMR as well as the apps. And we also have our sister managers from Sister Nur Aswana, Sister Suhaida, as well as Sister Yusma, all from the relevant departments that treat breast cancer patients. And of course, we have Mrs. Nofitria, who is our breast radiographer. And again, Prof. Sarinder, Prof. Samim from the FSKTM faculty is also involved in this study. And we have 3 research assistants, Ms. Shahira, and now we have a pre-house officer, Dr. Manisha, and Mr. Wong Seng Kai from the health informatics side. So where are we now? I have to say COVID really put a big challenge to Journey, because remember, the first step in any QIF is to engage the hospital management. And I think you can't blame them. They were struggling, and you can see from this year, we were all, it's quite difficult, I think, for everyone because of the massive Delta variant. So it was delayed until we were able to meet in July, where we started the work with the clinicians to look at the clinical pathways. And we will also be embarking on the patient needs study with Dr. Manisha and Dr. Tay, that will be leading that probably in November, because we've just gotten our ethics approval. Okay, and we will be getting on with the requirements. So we would expect that the configuration will straddle over to next year, and hopefully we can pilot this EMR dashboard and apps somewhere in February to March, and see how the patient as well the healthcare provider find it. And of course, when we do any quality improvement project, it is an iterative process. So we have to be patient, and hopefully we will get the ends at a time. And we hope that by May this year, because that's where our IIRG ends, is where we are able to at least produce a prototype. And of course, this all needs to be aligned with the aspirations of the hospital. And we know that there are apps currently being used already. So we will be aligning this, and we will be meeting our main stakeholder, the Research and Innovation Department, on the 2nd of November, which is next week. So this is so far the progress, where the requirements and the pathways are now being translated into something our health informatics colleagues understand. So it's sometimes like duck talking to chicken, chicken talking to duck, but it is something that I think whenever we do anything like this, the users are at the most important person in the whole team, because they are going to end up using the system. So that is why we have engaged very widely with our clinicians, and hopefully by making sure that we are aligned to the hospital as well as to the users, we will be able to produce something that will be very helpful, not just to the patients, but also to the healthcare providers. That's actually my last slide, Prof. Sarinda. So I'll stop there.
Okay, so this is your last slide. Yeah.
That was my last slide.
You want to present this workflow?
Pardon?
Do you want to present this workflow further?
I don't know. Do you all want to know? Okay, let me just say that we start off with the PUI, something like someone who we think have COVID, but in this case, someone we think who may have breast cancer that has entered into our hospital. So they could
Prof. Aisha, can you enlarge the workflow?
Okay, let me see. Wait, let me put on slideshow again. Okay, can you all see? It's very tiny. Let me see.
I think.
Not sure how to do that though.
Zoom, or you have the raw file that you can present.
Okay, I don't think I can make it bigger right now. But essentially, it will track the whole process of a patient who needs to be seen in clinic, who needs to have their radiology appointments, like mammogram, ultrasound, and eventually when they have their biopsy. So that is why we need to work in a multidisciplinary manner. So we have our radiologists who are actively involved with this, as well as our pathologist, Professor Man Kesiong, who will be giving us all the needed inputs so that we are able to draw this up. And maybe even Prof. Sarinda can comment what will happen after this, because when we work in teams, sometimes we're not aware about what our other team members need to have. So that is why this communication is very important between all the disciplines. We have a WhatsApp group, and I think we communicate, we see each other almost like every 2 weeks. And I think so far this is all about diagnosis. Yeah, this page is all just diagnosis. Dr. Nisha from oncology, and of course Dr. Tay, both of them have been working on the workflows and putting it into Excel sheets before this. And then our Mr. Wong from Health Informatics with Prof. Sarinda will transfer all those Excel information into this format that the health informatics people will understand. So I'm also looking forward to that 1 o'clock talk later. So we mustn't go too long, right, Prof. Sarinda, because we might have to answer some questions. So can we end here with Journey? I think you're muted, Sarinda.
Oh, so sorry.
Okay.
Okay. So sorry about that. Yeah, thank you, Prof. Aisha. I hope someday this Journey app will become a reality in the hospital, and we are working towards it. And we hope to see the app running in live in the hospital in UMMC. So thank you, Prof. Aisha, and congrats to all your effort. Yeah, so far in making this a reality. Okay, we have answered some of the questions earlier because we had some time earlier. So I think we only have one more question now for Dr. Liu. Dr. Liu, are you around? There's a question for you.
Hi, Prof. I'm still around. Yeah.
Yeah. Okay. Ever experienced the need to help patients who need financial aid? What did you do? So there's a question for.
Hi. So for that question, sorry, I just turned on my video. Hi. Hi. Yeah. Actually, even though we are a university hospital, it's quite frequent we encounter patient in needs for financial aid. So so far, since the implementation of this project until now, our financial counselor have been helping this needful patient. So one of the most common funds that is our diagnostic fund by our department. This is quite frequently there's a flow chart and also the application process for this diagnostic fund, UMMC diagnostic fund as well. So far, I mean, the most frequently we referred and educate patient is this diagnostic fund. Hello.
Diagnostic. What about treatment?
Treatment wise, so far, I mean, our role mainly is education, and we also referred those patients in financial toxicity to the medical social unit, and then we work hand in hand with our medical social unit staff, Puan Supia and her team, to help them to get the financial aids lah. So far for the treatment wise.
Medical social worker kan?
Yeah, medical social worker.
Yeah. Yeah, they are very
successful stories.
Cases, yeah. There are. I mean, a number of them, especially referred to Magna, gave a very good positive response, and really they help out of our patients, especially for Magna organization.
Do they bear the full amount, or they have a certain percentage?
No, so far, I mean, it's a limited lah. I mean, they will assess the patient first by medical social worker, and then so far, most of the time are not full amounts.
I see. So do you experience so far patients who had this financial difficulty and the patient decide not to carry on with treatment?
Actually, sorry, Prof. Yeah, I think you're trying to ask me, do I encounter any patients with real financial toxicity? Yeah, we do have. We do have some patients who are really unable to afford anything. So for those kind of patients where they are not, I mean, we try our best to help with the medical social worker, but there are also some cases where, I mean, they are really cannot afford any diagnosis and treatment in the UMMC. So we also educate them regarding alternative, like maybe considering, I mean, public hospital treatments.
Okay.
Ministry of Health Hospital, you mean?
Yeah, Ministry of Health Hospital, yeah.
Thank you,
Saida,
Dr.
we should take photos for our
yeah,
workshop.
definitely. Yeah. So, is there any staff who are available here to take a photo, or you want me to take a photo here?
No, let's take everybody open up their videos so that we can capture everyone here. Okay. So
What
let's
about I can only see the panelists. What about the attendees? The other participants?
Unfortunately, Professor, the attendees cannot because it's a one-way, this is Zoom webinar.
Okay.
So,
all right. Okay.
Okay, we're gonna take everyone's picture, all the panelists. Okay, smile. Another one. Okay. All right, brilliant. So we're gonna send this to all of you.
Okay.
For your report.
Yeah. So with this, we end today's session, and because there's another session at 1, I suppose. So we will have some break, at least 10 minutes of break before we start the second session. Thank you very much, everyone, and a very good session indeed, and hope to see you all again. And thanks, Prof. Aisha, for organizing, and also the Research Carnival Committee for all your assistance and so on. We'll see you again later. And anyone would like to say anything before we end? So I think that I guess nothing much. Okay, thank you so much again. Bye.
Bye.